The course is divided into the upper extremity, lower extremity, joint injections, peripheral nerve blocks, and finally spine. We have a lot of material to cover. And there we go. Okay, so just a little background about who I am and what I do. I'm the director of pain management at a hospital in Brooklyn. Some of you are from my ED. Some of you may have seen me online and understand a few of the things that I'm doing, which is board review for pain docs, as well as ultrasound guided pain procedures. And I am working hard to develop educational material to help educate any sort of clinician who may be interested in learning ultrasound or integrating it into your practice. And so over the years, I've worked with my emergency room to do studies on hip fracture patients, the femoral nerve block, the fascia iliaca blocks, as well as other projects in which I realized that there's really a deficit in the emergency room of skilled clinicians who can do these nerve blocks. And unlike a lot of the pain physicians out there who may look at other physicians doing these procedures as a competition, I look at it as something that's actually better for the society as a whole, as well as the patients. And it's something that really could, I think, be improved upon and expanded. And I'm sorry if I'm just trying to give somebody access to the webinar, but basically it's underutilized. And I think that there's a lot we can do. I've taught for AIUM, WAPMU, ASIPP, NRAP is a society I'm at the ground level for. It stands for Neuromodulation, Regional Anesthesia and Pain. As well as I have the podcast. I've developed regional anesthesia, acute and chronic pain rotations at my hospital, and so on. So just a little bit about PainExam. It's a CME course sponsored by my hospital, and it's 17 hours of lecture in case you want extra education. It'll give you an overall view of pain medicine. And we have a newsletter. So if you're not on the newsletter, then you sign up on the PainExam website and you should have the ability to access it. NRAP, once again, it stands for neuromodulation, which is spinal cord stimulation, peripheral nerve stimulation, regional anesthesia, which would be for perioperative, preoperative, postoperative, or pain procedures that we do in the office under fluoroscopy, ultrasound, for inpatients, outpatients, etc. Here's my disclosures. I do have some relationships with some companies. I will not focus on any of these companies today. Some you may see something mentioned, but it's not going to be particular to any one company. And if you have any questions after the review, I'll be more than happy to answer it. So take this down. If you're applying for CME credit, you should go to the phone number here. Just text 50 SURD and you'll have access to the credits. They'll email you a certificate. And if you're watching this in sometime in the future, you could try the link if it's active. If it's on the PainExam website, then you should be able to download a certificate. Okay, now I want to discuss, first of all, before we get involved with the actual nerve blocks, the safety, and that's with the risk of toxicity, okay? When a patient is getting a local anesthetic dose and they start to experience vascular uptake, they may first become confused, restless. They may experience tremors. They can report a metallic taste in their mouth. They can then go on to have convulsions, as well as seizures and cardiovascular collapse. So it's very important to understand how to treat these patients. and manage the crisis if it occurs. This is something that I've rarely seen. In my training, we had an episode that occurred right before my time with a dwarf who was getting a large dose of local anesthetic for a brachial plexus block. I've done beer blocks, which if you don't know what a beer block is, it's when you sanguinate the extremity, put up a tourniquet. This is after you put an IV in and you inject lidocaine, usually a very dilute lidocaine, not to give them a toxic reaction. And then during the surgeon will operate, and at some point you would lower one of the two tourniquets that you raised, and then you lower the other one. With this vascular uptake, you'll have some patients complain of a funny taste in the mouth or ringing in the ears. And so I've seen that happen. I've, thank God, never seen it progress to anything serious, but it's a risk. So it's something that you need to be aware of. And the treatment for it, especially as ED physician, right? Because if you have somebody presenting or having a local anesthetic toxic reaction, or you suspect it, immediately, of course, you stop the injection, you ask for help. You consider lipid emulsion therapy at the first sign of a serious event. And I would imagine if you're in the emergency room that you would be that you would have it available, but I'm not even sure if it's standard to have it. If you are going to be doing a lot of nerve blocks, I would have it. I know the operating rooms have it, as well as a lot of ambulatory surgical centers. You will need to make sure you notify the nearest bypass team, because it could be a prolonged resuscitation. Bupivacaine binds to the cardiac muscle and takes a while to dissociate, and therefore you may need to do a prolonged resuscitation until all that medication is metabolized or bound to the substrate. You want to, of course, manage the airway. You may need to intubate, control seizures. It's better to do a benzodiazepine over propofol, because benzodiazepine will be less likely to exacerbate any hypotension in a patient who you think is seizing or may seize. Propofol is not a standard seizure drug. However, if a patient is seizing, it can terminate the episode long enough for you to manage the airway, do what you need to do, stabilize the patient. Okay, of course, ACLS, start CPR. Now, intralipid is basically something that we use to act as a substrate. We give it as an IV bolus, 100 milliliters if the patient's over 70 kilograms, and the lipid emulsion is 20%. You give it rapidly over 2 to 3 minutes, and then 200 to 250 milliliters over 15 to 20 minutes. If they're less than 70 kilograms, you give 1.5 milliliters per kilogram of the lipid emulsion over 2 to 3 minutes, and then an infusion about 0.25 milliliters per kilogram per minute of the ideal body weight. Now, remember, I've never done this. This is something, thank God, I've never had to do. And I give these drugs all the time. If the patient's unstable, rebolus them, and you want to maybe use the same dose and double the infusion rate, but be aware there is a limit, 12 milliliters per kilogram. The total volume of lipid emulsion can approach 1 liter in a prolonged resuscitation, which is over 30 minutes. You want to continue to monitor the patient at least 4 to 6 hours after cardiovascular event, or at least 2 hours after a limited CNS event. Don't exceed 12 milliliters per kilogram of lipid emulsion, and this is especially in a small adult or child. And I get the details for this at the ASRA website. If you find that you want to keep up to date with this, check out ASRA, American Society of Regional Anesthesia, because they may update it every year and there might be changes to the guidelines. Okay, so if you've done nerve blocks, or at least if you've seen them done and they don't work, there could be many reasons why. Of course, you might not be targeting the right structure, and that really depends on your experience level. But septa could be between the needle tip and your nerve, and this could prevent spread on the nerve. You may actually be in a muscle, and if you're injecting inside the muscle, it's not going to reach the nerve unless that nerve is in the muscle, which happens sometimes. We'll talk about that later. You may not be focusing properly. You may not find your needle right. You may inject all the medication in one spot, and some of these larger nerves will actually, you need to get the medication around the whole nerve to get a full block. You may also misjudge your needle tip. You may not have your tip and your probe aligned properly, so you may see what you think is your needle tip, and it may not be that. So, reasons for failure with the ultrasound technique. If you're oblique to the needle and you're not exactly in line, you may see an elongated needle-like structure on the ultrasound, and you may be confused and think that that's your needle tip. Or if you're working out of plane, which I don't recommend for beginners, you're looking at a cross section of the needle, which appears as a dot, a hyperechoic dot, meaning it's looking whitish. And you may have some, so you might not be able to judge where the tip is. So you may actually, for instance, if you're doing an intercostal nerve block, you could be in the lung and not realize it because you're not focusing on the actual tip. So it's very important to understand how to visualize your full needle. This is something that I advise to practice with a phantom and an ultrasound. The phantom is a gel mold, which you could practice your needling skills. You stick the needle in it, you could line it up. If you don't have a phantom, you could use a piece of meat or something. And this, by the way, is not an introduction to ultrasound overall. I imagine a lot of you ED physicians have some training in ultrasound. You understand the theory. We will get into a little more about the different types of probes and the high frequency, low frequency. But I have a whole lecture on the intro to ultrasound, the theory, the physics, et cetera, and how to understand the knobs. This is more of an overview as to how the ultrasound can be applied in the emergency room. So it's a lot of material and not a lot of time, believe it or not. So I'm going to focus on all the cool things I'm doing, and then you could kind of choose what you're doing in your office, what would apply to your practice, excuse me. Okay, so take you back to med school, the brachial plexus. Okay, we have the brachial plexus, roots, trunks, divisions, cords. It starts in the neck, it leaves the cervical spine from usually C5 to T1. The interscalene brachial plexus is one of the first areas that us as interventional pain physicians or anesthesiologists will target. Then the supraclavicular brachial plexus, then the infraclavicular brachial plexus, and then the axillary brachial plexus. So roots, trunks, divisions at the supraclavicular, then cords at the infraclavicular, and then finally the axillary level, you're having different branches. Okay. I think this is all review from med school. Perhaps they can go over the locations, the interscalene, supraclavicular, infraclavicular, and axillary, but these are typically the way we refer to the brachial plexus when it comes to nerve blocks. Now, do not get confused between the axillary brachial plexus and the axillary nerve. Okay, axillary brachial plexus is the group of nerves in the armpit surrounding the axillary artery. The axillary nerve is a nerve that we'll get into soon, all the details about how it innervates the deltoid and how we can block it or why we would block it. So the interscalene brachial plexus block provides anesthesia of the shoulder, lateral clavicle, proximal humerus, and elbow. Okay, so when we're doing the interscalene block, you're not looking to get the ulnar division or the ulnar nerve anesthetized, okay? So keep in mind, it's almost a whole upper extremity with the exception of the ulnar nerve, because the ulnar nerve joins the brachial plexus lower down. It has fibers from C7, 8, T1, and therefore you don't get it because you're too high up in the neck. So in the interscalene fossa, you have the middle scalene and the anterior scalene, more anteriorly. In between them, the brachial plexus appears as hypoechoic or black cross-section of nerves. They're circular. The interscaling brachial plexus block is traditionally not done in a pain office, nor is it done in an ER usually. However, there are certain situations where it can be very useful. One can be the patient who presents with brachial neuritis or even cervical radiculopathy, and they have a Tinel's in the interscaling fossa, which you could palpate on yourself. And it's basically that groove behind the sternocleidomastoid that you're just more sensitive, and you could kind of palpate the nerve. Remember, I don't know if you know, when you're a kid, kids like to touch each other's pressure points. At least when I was a kid, this is what kids would always do. They'd see how long you could stand it if somebody touched your pressure point. These are typically points where you have nerves, such as here, it's the carpal tunnel or the median nerve. You could find your own interscaling just by feeling it. Okay, it's just that annoying spot right above the clavicle between the muscle bellies. The interscaling block will be useful for shoulder pain, brachial neuritis, frozen shoulder. There was an article I talked about on the PainExam podcast about ER physicians using the interscaling block versus propofol to do a shoulder reduction for a dislocation. And the brachial plexus will not get the C7 to T1, as I mentioned earlier. So in the past, when I was in training, believe it or not, I'm old enough to remember the paresthesia technique, which is basically stick a needle next to a nerve until you get paresthesias and then inject. That was also accompanied by the twitch, the nerve stimulator, which we would put a needle with electrical power to it and stimulate the nerve and then see twitches in the appropriate muscles and then inject. But you're not actually seeing the nerve, and therefore you were having to give larger doses of local anesthetic. And also this was something that was really not in the patient's best interest because you could damage the nerve. Ultrasound actually solved a lot of those problems. Here we're looking at a parasagittal section of the neck. So basically we're just cutting the patient down off the midline in the sagittal section. And you can appreciate that in the interscaling region, if you're not careful, you could get into many different compartments. You get into the artery, the carotid artery, the intrajugular vein, the vertebral artery, you get into the pleura, cervical spinal cord. So this is something you need to be very careful with. Now, this picture is actually, I would call it the junction between the interscaling and the supraclavicular brachial plexus block. So back to the interscaling. We position our probe as such, okay? And between the scalene muscles, you're looking at a cross-section of the nerves. You're looking at circular hypoechoic nerves that are lining up. Typically, the most superficial is usually C5, then C6, then C7. Sometimes C5 is in the muscle belly of the scalene muscles. And here's another image where we're scanning. Okay, this is the interscaling fossa. And watch the probe as you watch the ultrasound. Okay, we're now going to go down and change the angle to look at the supraclavicular fossa, where you see the subclavian artery and the nerves right above it as divisions. And now we're going to go back up again into the interscaling fossa and find the nerves. Okay, so if you can't find the nerves, always look at the subclavian artery and just scan up. That's the anterior scalene muscle, and here's the middle scalene muscle. Okay. If there's any questions, feel free to put them in the chat section or the Q&A. Okay, so with ultrasound, you have less tissue disruption from repeated needle sticks. You're giving less local anesthetic, as I mentioned. You're actually visualizing the structure when you're doing the procedure, and you're repositioning to ensure that you get the local around the nerve that you're targeting. And you also have assurance that you're not going vascular. You could put on Doppler, you could visualize the blood vessels, so it's a lot safer, in my opinion. Now, another way to locate the brachial plexus, you could start in the anterior midline of the level of the thyroid and then move laterally. You could look for the carotid, IJ, then the anterior and middle scalenes, and the sternocleidomastoid. So that's the thyroid gland. Okay, we're right here in the neck, in the carotid artery. We're going lateral, and then we're angling it to see the nerves. Okay, it helps sometimes to angle upwards like this to find the nerves to the brachial plexus. Okay, now we're actually scanning up and back a little bit, and we can even see how the nerves come back into the spine, which is more relevant for the interventional pain world, not so much in the emergency room. However, it's good to know. Okay, just another picture, because you need to get this in your brain when you're looking for this. Now, a lot of anesthesiologists, I'm not going to say pain docs, really anesthesiologists will think I'm nuts for teaching you guys this, because the interscalene block can also predispose the patient to a phrenic nerve block. And the patients really need to be monitored. And in the emergency room, you might have great monitoring, you may not. It depends on how busy you are and your staffing, right? It really, everything is relative to where you are and how many people are around at the time, and actually how much medication you're giving the patient. So this is another image of the interscalene brachial plexus block. This is using a high resolution, high frequency ultrasound probe. It sees the superficial structures better than a low frequency would. And you're lining up those nerves that I mentioned. Variants in the anatomy, you have C5 and 6 pass through the belly of the anterior scalene at time. And it may look like a black hole in the middle of the muscle. You can inject around it. You can also put Doppler on to make sure it's not an artery. In fact, you should, and you have to put Doppler on because God forbid you inject an artery in someone's neck, you're going to be in big trouble. And I always give 1 or 2 milliliters as a test dose just to make sure, usually half a milliliter to 1 milliliter, depending on what you're injecting. And there are ways to do this in a safe way without getting the phrenic nerve palsy or of it not being of big consequence. And that's why I'm presenting it here. Because I've been in situations where I didn't have access to an X-ray machine for a cervical epidural, and I've been in an office with just an ultrasound and not much resuscitative equipment, and I've had to treat this. So there's a way to do this very safe, but of course it requires a lot of practice. So if a patient comes in with acute cervical radiculopathy or a pinched nerve in the neck, and the typical presentation is that they put their hand right here. I have a pinched nerve in my neck, it's going down my hand. Patients can respond to a peripheral nerve block for a central pathology, meaning central pathology, disc herniation in the neck, and the peripheral manifestation would be that radiation down the arm, muscle spasm, Tinel sign, localized pain over the nerves. Okay, here's a patient who came to me in the office, 58-year-old. He had anterior and posterior surgical fusion in his neck with hardware. He had 4 surgeries. He had a lot of pain, and he presents with atrophy of the left arm and pain from the left shoulder down to his hand, and he had Tinels over the interscalene fossa. This gentleman couldn't get an epidural because the epidural space was operated upon and it wouldn't be safe. There's too much scar tissue. The epidural is a procedure we do with visualization. However, there's also a field component where you're looking for a loss of resistance, and it would be impossible on this patient. So I took the probe to the side of his neck and I injected the brachial plexus where he had his Tinels. And you'll see my needle coming in from the left over here. Okay, and I'm getting into the sheath around the brachial plexus, which is right here. And I only give a dilute mixture of dexamethasone, saline, and either lidocaine or bupivacaine. I don't give any large doses that would predispose to any serious phrenic nerve pathology or anesthesia toxicity. Okay, so moving on to patients who present with cervical radiculopathy. Okay, cervical radiculopathy is a funny thing. the standard of care, if someone fails physical therapy, conservative therapy, and PO analgesics such as gabapentin, Lyrica, Tylenol, ibuprofen, etc., would be a cervical epidural steroid injection. In my practice, I choose not to do that so soon. I do cervical epidurals. They work very well, but if God forbid you have a bleed, infection, or trauma to the spinal cord, game over, quadriplegia, instant death. There are case reports every year of this happening in pain practices. I don't know if you've seen this happen in the emergency room. I do know that in my hospital, Maimonides, in the past, we have had patients from other pain doctors admitted for hematomas, and these patients are devastated. It's just an awful thing. So I'm very leery of this. And in my practice, if I can avoid the cervical epidurals, I do. Nevertheless, I do them, but they're not my first line. They're probably a step before surgery. So this is the supraclavicular block, which similarly to the interscalene, occasionally a patient will have a Tinel's over the supraclavicular fossa, and they'll benefit from an injection here for brachial neuritis or cervical radiculopathy or any sort of shoulder or arm pain. So this is a reliable block for pain distal to the shoulder. However, it may or it may not get the shoulder. The big question is it getting the suprascapular nerve block, which comes off at some point in the supraclavicular fossa. So if you're getting that, then you'll get more shoulder coverage. If you're not getting it, you will. Okay, so this is that parasagittal view we showed you earlier. I'm including it here because it's part of the supraclavicular brachial plexus as well. The subclavian artery is the most important landmark. Insertion of the anterior scalene into the first rib lies between the vein anteriorly and the subclavian artery posteriorly. On ultrasound, the vein is well forward of the artery, and most of the time it's hidden below the clavicle. Okay, here's what it looks like on ultrasound. We're taking our probe, we're resting it above the clavicle. And this could be a super safe and a super dangerous shot. So you need to think of how you approach it, and I'll show you how I approach it. So first you have the subclavian artery here, and then you have the first rib. The nerves are above and to the side of the artery. Now here's a video of me doing the supraclavicular block in the office. I'm anesthetizing a shoulder, believe it or not, for a patient who's getting PRP injection and stem cells or bone marrow aspirate injection to his shoulder. And I don't want to give any local in the shoulder to interfere with the regenerative therapy. But this same technique you could do in the emergency room once you're confident and comfortable, because the lung is right below that rib that you see here, that dark spot. And my needle here is sliding towards the brachial plexus, and I'm slowly injecting around it. I'm giving just a little bupivacaine to anesthetize the brachial plexus so the patient doesn't have much pain from the injection. All that black below is bone shadow and lung, except for the artery to the left, that circular structure. See, I'm getting into the sheath. I'm not going into any of the nerves. I'm going to get just into that area where the nerves are being held, which is kind of a compartment, and letting it spread. But I'm usually going to different spots. Now, the anesthesiologist, as you see that red line, he takes a different approach with the patient lying down usually, and will not do this procedure sitting up because he's giving larger doses of local anesthetic. There could be more of a risk of a vagal. And therefore, because he's aiming at the lung, there's more of a concern of pneumothorax. With the supraclavicular nerve block, you actually can get some paralyzed phrenic, the hemidiaphragm from the phrenic nerve block. So be careful with it, but it's less likely than the interscalene block. The supraclavicular block is great for any sort of pain or procedure of the upper arm down to the hand. Okay, pneumothorax is the big risk with the supraclavicular block, so be careful. In the pain office or in the emergency room, you could treat brachial neuritis, any sort of injury that's causing pain to the arm. And to keep the doses low, I won't give more than 0.25% bupivacaine or dilute it to 1.25 with saline. and add 2 to 4 milligrams dexamethasone. Above 4 milligrams dexamethasone, a lot of the studies show that there's not much of a benefit, but dexamethasone does prolong the duration of the local anesthetic, and it can reduce inflammation, of course. So tips, if you're doing the supraclavicular block and you're doing it the way I'm doing it with the patient sitting up, of course, you're worried about vagal. I've never seen a vagal with this procedure. I've seen vagals from other procedures. For some reason, I just haven't. So I'm not saying it won't happen, but I've done really like thousands of nerve blocks. And this is something that I'm confident doing the way I did in that video that I just showed you. So the lung can be avoided. Just keep control of the block needle and keep in the plane of the probe's beam at all times. Proceed slowly and make sure that you can see your full needle. And then try to get the local anesthetic in different areas in the sheath to make sure that you get even spread. Hopefully you don't need to redirect too many times because that could predispose to further trauma. And stay away from the lungs, right? Okay, the infraclavicular brachial plexus block. I basically grew up on this block. At Bellevue, we were doing a lot of hand cases because our hand service was taking care of a lot of patients who would be weekend, I guess, contractors, people who would work in their garage on the weekends, chop off a few fingers, then they come in, and the junior resident on call got stuck watching the patient for a 24-hour surgery while the senior resident would get to do the nerve block. And the nerve block was basically sticking, back then we didn't even have block kits. We took an epidural needle and we would just put it into the infraclavicular region and look for the brachial plexus and run a catheter there so we could rebolus the patient if they're coming back for surgery, which happened quite frequently because sometimes the graft would go down and the surgeon would lose the pulses and would want to redo his anastomosis. So the indications for the infraclavicular block are similar to the supraclavicular, but you're not getting any shoulder here. Anything distal to the upper arm is fair game. And we would place the probe right under the clavicle. You're lateral to the lung, okay? So the lung should not be much of an issue here. Here you have pec major, more superficial, pec minor below it. The lateral cord is lateral, or in this case, superior to the subclavian artery. The medial cord is between the blood vessels, and the posterior cord is deep to the subclavian artery. The infraclavicular brachial plexus block, low risk of pneumothorax, easy and safe to do with ultrasound guidance, pretty quick to set up, and you can place a catheter here. So if you're really slick and experienced with these, if you're in the emergency room and the patient's going to be admitted, and I mean, listen, you need to get the primary service on board, anesthesia, the pain service, and surgeons. But if you place a catheter in the ER and the patient goes up to the floor for whatever they're doing, and this is a general statement, it may benefit the patient in some ways. That's what we were doing in the ER with our femoral nerve block study with the fascial block was performed first by ER physicians for a hip fracture, and then me and the other pain docs would come down to the ER, do a femoral nerve block with a catheter, send the patient up to the floor, and we were able to reduce morphine requirements on elderly patients. So a little bit about the probes and the high versus low frequency, okay? And I'm putting on this slide because for the most part, I've been showing you high frequency probes, which is what I usually use, because the high frequency probes have improved that you are still getting a fairly deep image, even though the lower frequency probes are meant for deeper images. The low frequency probe in the infraclavicular fossa has the advantage because it's a curved probe and it may be deep. So the deepness, of course, is an obvious advantage, but the curve will give you the advantage of being able to get that needle between the clavicle and the probe, which you sometimes can't do very well with the flat ultrasound probe. So it's something to consider when you're choosing which probe to use. And in the emergency room, I imagine you have both available. If I had one choice, I would use the high frequency because I do, and I mean, I still can manage fairly well with almost any patient with this. But if you were starting out, I would suggest you always use the low for the deeper structures and the high for the more superficial structures. Since the neck and the arms are really not really deep structures, I recommend high frequency in these regions. So once again, the chords are hyperechoic. The lateral cord is most cephalad. Posterior cord is posterior to the artery. And the middle cord or the medial cord is between the blood vessels. Now, when you're doing the block, you're going to have your needle first go to the middle cord, pull back, go to the lateral cord. And then this is the, I guess, tricky part. You want to actually scoop up the artery and go to the posterior cord. And if you're placing a catheter, this is where you would do it. Okay, this is a more advanced procedure. I'm not recommending you to just watch this webinar and just do it. Make sure if you're doing it, you're with someone who's done them before. And if you look at the image over here, this is the pink circle above the ultrasound is where your needle entry point is. I will be doing hands-on training, hopefully, and I think April 18th might be the first day we're doing it. If you're interested in getting and reserving a slot, let me know, because of the pandemic, we're limiting space. So just keep me posted if you're interested. Okay, so here are two images. One is with a low frequency probe. This is one of the older ones. The newer low frequency probes actually look a lot nicer, but this is what I had. And the other one's with the high frequency probe. And you can see the high frequency probe is definitely less grainy and looks nicer. But as I mentioned before, there's an advantage of the smaller and curved probe head with the low frequency and you're getting your needle in the right spot. Okay, moving on to the axillary brachial plexus block. You have the median, radial, and ulnar nerves around the axillary artery. The radial artery is deep to the axillary artery. The muscocutaneous nerve is usually pretty easy to find nearby. It's a very, this is a pretty old block. We've been doing this one for a while. Back in the olden days, we would use the pulse and not even use imaging. We would palpate the pulse, the axillary artery. We would aspirate blood, then go through the other side of the artery until blood did not aspirate and inject, pull back, aspirate blood again, pull back till the aspiration stopped, inject again, and you should theoretically get the radial, medial, and ulnar nerves. Of course, that's fallen out of favor once the ultrasound came around, and it's pretty easy to find even in obese patients, and it's quite useful for anything distal to the humerus, to the upper humerus. You do need to get the muscocutaneous nerve, which is separate. It's in the coracobrachialis muscle, if you can see here in the picture. It's not in the same sheath because it's already separated. So patients will typically be supine with their arm outstretched when you do this block, and your needle comes from above, like in this picture. And you can identify the artery because it has more resistance than the nerve to the collapse. Okay, with pressure from the ultrasound probe. So lateral to the artery is the median nerve. On the other side of the axillary artery, which is medial anatomically, you have the radial nerve, and the ulnar nerve lies more medial. Now, just a very common board review question for us pain doctors is, what nerve is deep to the axillary artery when you inject it? And the answer is the radial nerve. Okay, this is just a very, very common question that we see on the pain boards. And there you go. So this is a little video of the axillary brachial plexus block. The ulnar nerve. Remember, the probe is right here like this. Radial nerve. And the muscocutaneous nerve is often the coracobrachialis muscle, which is actually, it's above it. So when you're coming here, you're just sliding up here, okay, to get that muscle. Okay, just a picture of what it looks like after you inject. That's the humerus, that hyperlucency below. Here you have the arm dissected out. You can appreciate how the nerves branch off. This is back from your anatomy days, but it's a good picture to look at every now and then to understand the upper extremity innervation. So the radial nerve leaves the radial artery with the profunda brachial artery in the axilla to innervate the triceps muscle. The profunda brachial artery follows the radial nerve as it moves from the axillary artery towards the spiral groove of the humerus. It can be damaged with humerus fractures. The radial nerve is from the posterior cord of the brachial plexus. It innervates the extensor supinator group and provides sensory innervation to the posterior aspect of the elbow, forearm, and hand. And these are the codes you would bill when you do this. Now, I'm not an ER doctor or someone who codes in the ER, but I would imagine procedures in the ER actually get paid for, especially if you're saving the insurance company's money by enabling adequate pain relief for discharge to follow up with an appropriate specialist, orthopedic, pain management, et cetera. If I'm wrong about that, let me know, but that's my understanding. I know when I get called to do a procedure in the ER, they're more likely to pay for it than not, because in the end, it's better for the patient and saves them money. If any of you have anything to add to that, if any of you are administrators in your ER or know anything about billing for these things in the ER, please feel free to share it with us in the chat room. Okay, the radial nerve, you can get it at the wrist. It's basically next to the artery. It's at hyperlucency. In this case, it's below the artery, since it's to the side of the artery. It varies sometimes. Or you could get it under the brachioradialis muscle in the forearm. Every now and then there'll be an entrapment here or some sort of pain here, and I do a nerve block there in the office and patients get better. So the median nerve block, superficial to the axillary artery in the axilla, crosses the front of the artery from lateral to medial and can be displaced to either side of the axillary artery with transducer compression. It's formed from the medial and lateral cords of the brachial plexus. There's no branches to the upper arm. It passes between the heads of the pronator teres. There is actually a pronator teres syndrome in which the nerve's entrapped there. It gives off palmar cutaneous branches and it passes below the flexor retinaculum. Now the nerve block is coded 64450, which is just another peripheral nerve block in the cubital fossa. However, if you're doing a carpal tunnel sheath injection where the median nerve enters the sheath, you would do a 20526. Then you add, of course, the ultrasound guidance code, which is 76942. And at this point in time, they're separate. These codes are bundled for certain other procedures, such as caudal epidurals or a joint injection. So for carpal tunnel, I don't imagine many patients come to the emergency room with carpal tunnel, but from my recollection being a student rotating through the ER, people do come to the emergency room for anything and everything. So why not, right? It is possible. So you have here the flexor carpi radialis tendon. Okay, we're scanning cross-section of the wrist. You have the median nerve. Now right here, this is the median nerve before it enters the carpal tunnel. Below it is the flexor carpi digitorum and the profundus and superficialis tendons. So this is just an image of a median nerve block right before the carpal tunnel. One way to identify the median nerve from those tendons is to have the patients wiggle their fingers, because it looks like this structure under my needle right now is a nerve, but it's actually a tendon. Okay, the nerve is actually above my needle right now, and I'm doing a hydrodissection to get above it. And it looks like I get really close to the needle, to the nerve right here. You see, I did not enter the nerve, but the fluid went around it, and it looked like some of the fluid dissected between the nerve, the fascicles. Either way, the patient did very well and had relief. The ulnar nerve. So this arises from the medial cord of the brachial plexus. In the arm, the ulnar nerve lies between the axillary artery and axillary vein in the axilla. It's the same CPT code as the others. You get cubital tunnel syndrome, which is entrapment at the cubital canal, cubital tunnel, I should say. And that is basically like a funny bone type of pain with a Tinel sign over the tunnel. Some patients need surgery, an ulnar nerve transposition, where they take the ulnar nerve, they move it to the side, or they can get by with just an injection. So Here's the nerve up here. This bone shadow is the cubital tunnel. And the needle is right above it. You have to be very careful not to stab the nerve or inject it, especially when the nerve is fixed within the tunnel. And you see a little air got into this injection. I left that there because of it will happen from time to time if you're not careful. And it's good to kind of see what could happen if you're not getting the air out of your syringe. Okay, so the ulnar nerve could be bright, hyperechoic, triangular, oval, etc. There's different, it looks differently sometimes depending on the orientation of the ultrasound probe. It joins the ulnar side of the artery in the forearm where it is surrounded by the flexor digitorum superficialis, profundus, and flexor carpi ulnaris muscles. In the distal forearm, the ulnar nerve will lie adjacent to the flexor carpi ulnaris tendon. Okay, it can actually get entrapped in Guyon's canal, which is more distal at the wrist. And you may need to do a wrist injection as well. Okay, this is a very important one for the emergency room. The suprascapular nerve block. It's one of the most common procedures I do in my office for a variety of reasons, and I'll get into that soon. But the anatomy. So just to review, you have the supraspinatus muscle, the infraspinatus muscle. The trapezius muscle is a big diamond-shaped muscle that covers everything above. Then you have your teres minor above and your teres major below with your triceps. Suprascapular nerve. Now, you all remember from anatomy the notch of the scapula, right, where the nerve enters. I don't really bother with that much since I have an ultrasound. I look to get the nerve somewhere else. So the nerve, it innervates supraspinatus and infraspinatus as well as 80% of the shoulder. It wraps around to go inferior to the spine of the scapula and get the infraspinatus muscle. Okay, it also gets the supraspinatus muscle. When you're looking under ultrasound, you're placing the ultrasound above the spine of the scapula like it's resting on a shelf. And you're going lateral to visualize the nerve at the bottom, as you see here. And it's covered with a transverse scapular ligament, that white above the nerve. You have the scapula, the hyperechoic, hyperlucent with a shadow behind it. Then you have the trapezius is the most superficial muscle and the supraspinatus muscle above it. So the innervation, once again, infraspinatus, supraspinatus, essential portions of the capsule, ligaments, and the shoulder joint. The nerve doesn't supply any skin of its own. So here is the view with the ultrasound. Okay, you're scanning as the nerve kind of, you get like a cross section of the nerve as it's about to dive down and loop back to infraspinatus and send some fibers to the shoulder. Now, here's a video of me doing it in the office. I use a 25 gauge 3.5 inch needle for a lot of these blocks. It hurts less. It is a sharp needle. I've never had any nerve damage from this needle. You might want to use a blunt needle or a hyperechoic needle when you start this in your practice, when you start out using ultrasound, just to make it easier to see. Here I'm injecting, and sometimes you don't get exactly by the nerve, but you get onto the bone under the ligament next to the nerve, and the fluid will flow over the nerve as long as you're under the ligament. Here I'm taking another pass, it looks like. Okay, so why would we do this, I guess, is a question you're probably thinking of. So the suprascapular nerve block, and you can see the suprascapular nerve here, it's another image, as well as the supraspinatus tendon, is good for tendinopathies of the rotator cuff, especially supraspinatus and infraspinatus muscles, frozen shoulder. When patients come in with cervical radiculopathy, one of the first things they do is say, oh, I got a pinched nerve and it's going to my shoulder. And they're pointing to their supraspinatus nerve. So doing this nerve block can accomplish a few things. When you can get a pharmacological or neurological separation of the supraspinatus, infraspinatus nerves from the neck muscles and alleviate symptoms up here. And every now and then patients will tell me their hand is getting warm or they're feeling numbness in their fingers or relief of their hand or arm pain from this block. And I don't have an exact reason for that. My guess is that there's some traction of the nerve to the axillary brachial plexus. Some of it is just sliding down. So evidence for suprascapular nerve blocks, there's plenty of it. It could help with hemiplegic shoulder pain. And by the way, you don't even need steroids for this to work. You could just do bupivacaine 5 mLs or lidocaine 2%. You could treat frozen shoulder. This will help you with manipulations under anesthesia. It's a lot less risky than an interscalene or supraclavicular brachial plexus block, a lot safer to do. I really do this for shoulder pain in patients who you don't want to give steroids to or failed the joint injections. Post-operative, let's say the surgeon did some procedure and you don't want to mess with the joint or the rotator cuff tendons, you could just do the nerve block. It could treat arthritis. It could treat all sorts of pain problems, and it's been shown to be effective at 18 months afterwards even. So the axillary nerve block, you have the quadrangular space. The axillary nerve comes off the brachial plexus and it will divide. It'll go towards the shoulder joint. It'll go towards the deltoid muscle. It'll go back towards the teres minor muscle. And this is how we find it. The nerve is motor for deltoid, long head of triceps, and teres minor. It's sensory for the skin. It's called the regimental band, they call it. It's like a patch that a soldier would wear in that area. It also covers a good part of the shoulder joint. And the name of the nerve that goes to the skin is the superior lateral cutaneous branch of the axillary nerve. Okay, so here's an image under ultrasound. The nerve could look almost any form, circular, oval, like a line, because it's basically, it's coming at you and branching out under ultrasound. So it doesn't have to look one particular way, but you'll recognize it based on the relationship to other structures, which I'll show you in a second. Okay, here's a video for the axillary nerve. You have the quadrangular space, and you have the probe, which you go longitudinally here, sorry. And it's going to slide into the quadrangular space, visualize the teres minor above, teres major below. Okay, muscles have dark with white bands, and that's because they contain a lot of fluid. Any connective tissue or nerve is more hyperechoic, it's whiter. So here you can find the teres major muscle below, teres minor above it, and you're getting a cross section, which is the axillary nerve between them, with the artery, posterior humeral circumflex artery, right next to it. Okay, so you guys are going to have the replay available. So if any of your friends want to check it out, or they can go to the PainExam website and sign up for it, as well as if you paid for or registered already, you can go back and watch this. I know it's not, you're going to just not walk out of here and start doing everything like someone who's been doing it for years, but you have to start somewhere. So I'm giving you the overview. Is there any questions now before we take a break? Okay, so I'll see you guys back in about, let's say about 11:10. Okay, welcome back. And before I get into the next unit of the talk, I just wanted to get some feedback so I can make sure that I'm directing this right way, as this is my first ER only nerve block course. If I'm talking above your level or below your level, or if it's too much anesthesia and not what you think you can apply to the ER, let me know. I think a lot of this you can apply as long as you're doing it carefully and are able to visualize your needle. So once again, as a reminder, if you don't have a way to practice the needling, buy one of those phantoms. Unfortunately, not so cheap. The cheapest I found was about $200. So maybe your department can buy it, or you and a bunch of other colleagues can buy it to practice on, and that will give you the confidence to be able to find your needle tip. When it comes to these nerve blocks, there's really a few different aspects that you need to really master. One is, of course, knowing the indication for doing it and the possible complications. The other is the anatomy, knowing what to look for. And then lastly, and maybe most importantly, is being able to find your needle with the ultrasound and giving the appropriate doses, of course. So once again, the chat's open or Q&A on the Zoom, so you can just ask or type whatever you want to know about. And if you want me to slow down and go over something again, just let me know. Okay, so we're going to move on with the lower extremity. Okay, so we'll start with the lumbar plexus. The three main terminal branches of the lumbar plexus are the femoral nerve, which is from L2 to L4, the obturator nerve from L2, 3, and 4, and then the lateral femoral cutaneous nerve from L2 to 3. Of course, you have the iliohypogastric nerve, ilioinguinal nerve, genitofemoral nerve, and there are other branches of all these nerves, but these are the main branches that come off and that we target for our nerve block. So starting with the femoral nerve block. So the block provides anesthesia to the anterior thigh, medial lower leg. It goes to it branches off to the saphenous nerve, which is basically a branch that goes to the knee through the infrapatellar saphenous nerve and then down the medial aspect of the foot. And this branch actually is mainly a sensory branch, not motor. Patients who've had any sort of knee pain from surgery, from other pathology to the knee, can benefit from a femoral nerve block. You could use this for below the knee amputations or above the knee amputations, as long as you compensate with a sciatic nerve block as well. Between the femoral and sciatic, you should get full anesthesia of the lower extremity. So in the pain office or ER, why would we do a femoral nerve block? Well, you guys already know about the hip fractures. We talked about that. And that's a big deal, by the way, especially in my hospital, Maimonides, because we see a lot of hip fractures, a lot of elderly patients in the community. And if you could really reduce the amount of morphine not needed, and pain and suffering, of course, then more power to you. Other reasons for femoral nerve blocks. Now, remember, when I say femoral nerve block, right now I'm talking about getting the nerve proximal in the inguinal region or in the upper thigh. You can get it lower down in the mid-thigh by the adductor canal and minimize the motor block, meaning if you want to keep the quads intact, you go more distal. But a femoral nerve block will basically take care of the quads as well. So let's say you have some sort of tendon rupture or patellar fracture, this will help. I've had patients present to my office after they've had a vascular procedure, such as a cardiac catheterization, and the cardiologist actually stabbed the femoral nerve or injected into it during the cannulation of the artery. So they could have neuralgia for all sorts of reasons. There could be a tumor there. There could be other sorts of pathologies. So this is a pretty easy to do block. You just need to watch out for the femoral artery and vein. If you remember naval from med school, nerve, artery, vein, here it's reversed. The nerve is on the right. So the nerve lies deep to the iliopectinal arch and overlying the groove between the iliac and psoas muscles. There are two layers of fascia beneath the skin. Superficially, you have the fascia lata, and then deeper is the fascia iliacus, or the iliacus fascia, hence the fascia iliaca block, which we'll talk about soon. So if you look at this picture here, the femoral vein, the vein can be bigger than the artery or smaller than the artery. It really depends on position and the patient's venous capacitance or central venous pressure. The femoral artery is typically circular when you get a cross section, and it's pulsatile, more resistant to compression. And then laterally, you have the femoral nerve, which could be oval, triangular, rectangular, but more trapezoid, not rectangular, but it can have all sorts of shapes. And then if you see here in the diagram, there's also the obturator nerve, which does the adduction. So there are no muscles overlying the femoral nerve at its position at the top of the thigh. The femoral nerve begins sending branches laterally soon after passing under the inguinal ligament. The first branch usually innervates the sartorius muscle. The code for the femoral nerve block is the 64447 code and the 76942 code. Something else I didn't mention that we're doing with the femoral nerve block, in addition, is neuromodulation, which many of you may or may not know what that is. Under ultrasound or X-ray, but in the case of most of these nerve blocks, we're actually placing wires onto these nerves and either giving them a 2-month system or a permanent system, meaning for 2 months, they could wear a wire going from the nerve through the skin, secured with dermabond and tegaderm, to a battery that's a sticker that they put on their skin, and they can have a remote control in a necklace or on their iPhone app, and they can control the stimulation to the femoral nerve or to any nerve. It's not just femoral. We're doing it for shoulder pain, the axillary nerve. I'm doing it for back pain to the medial branch nerves. And these patients are getting excellent relief. The 2-month system is great for some patients because some patients don't need more than 2 months. Sometimes the problem is cured with the stimulation. Sometimes the problem comes back after the stimulation is off, but oftentimes when the nerve is stimulated, it reduces pain for quite a while. So that's one route, the 2-month system. There is a permanent system in which we first do a trial in the office where we put a needle next to the nerve, stimulate it for, I don't know, a half hour, maybe put a catheter there, let them walk around for a bit, connected to a remote control. Then we take it out in the office, they go home, they think about it. If they want it, we then implant a wire permanently. We get it by the nerve, run it under the skin where the receiving end is, and then we close it with sutures. That heals, and you put a sticker with a battery on a few hours a day in the morning before they get out of the house, and they're charged for the day, and they can go about their business and have less pain. And it's really been a game changer in the pain office. This and of course, regional medicine, regenerative medicine, such as PRP and stem cells, bone marrow aspirate. It's really been very helpful in minimizing opiates and giving longer term relief, as well as safer therapies than steroids. Okay, so we talked about locating the femoral nerve. Here's another image of that. Here's where my probe would be. Okay. And that's the nerve over there. Okay, for your X-ray vision, you could see how the probe is going over the femoral nerve and in the fascia iliaca location, and the red nerve is the lateral femoral cutaneous nerve. So the landmarks for the fascia iliaca are the pubic tubercle and the anterior superior iliac spine. You draw an imaginary or real line there, depending on if you want to draw on your patients. Connect and divide the line into thirds. Now, this is the old-fashioned way of doing it without the ultrasound. I'm just giving you an idea as to how we used to do it. So it sometimes helps you understand where to place your probe. You're going to use the 1/3, 2/3 lateral junction for your landmark. And with a blunt needle, you're going to go perpendicular to that point and pop through the fascia lata, then the fascia iliaca, aspirate, and inject. Now, of course, with the ultrasound, you don't need to do all that. You could just find the fascia iliaca, which is lying over the iliacus muscle, which I should have an image of coming up soon. But here's one of those ER studies I mentioned about the hip fractures and how they're able to reduce post-procedure pain, and that there were no complications, that was safe to do. Okay, so let me just see if I go back a drop. I should have an image for you if I missed it. Okay, it's probably later on, but there's an image of the ultrasound over the fascia iliac, and I think my femoral nerve video, which if I don't have it here, I'll try to show it to you later. Okay, saphenous nerve, we mentioned, is a branch of the femoral nerve. It innervates the knee and the medial lower leg. It sends a branch to the patella called the infrapatellar branch. So you get some resolution of knee pain in some patients with this block. Before I knew how to do genicular nerve blocks, I was doing saphenous nerve blocks for knee pain, and I was giving some good pain relief for a few months, but just local anesthetic and a little steroid. So one of our docs here has a question. When should I use the femoral nerve block versus the fascia iliaca block? It's a great question. Well, the fascia iliaca is lateral to the, it's the iliacus muscle. It's getting some of the fibers of the femoral nerve in a compartment over it. So you could get a full-on femoral nerve block with the fascia iliaca block if you give enough volume, or using a femoral nerve if you give enough volume, like 30, 40 mLs, and you put distal pressure, you can get more proximal spread that will also get the other branches, such as the obturator nerve, the adductor nerve. These are all considered the 3-in-1 block. So when you should use one versus the other, well, it really depends. If there's an issue more with, like, let's say knee pain or distal, I'd use the femoral nerve block. If it's more of a hip issue, probably fascia iliaca would be my first bet. I think I would go there first because, well, the truth is you're going to get relief with both. The question is, I think it really depends on the patient's anatomy, because there's variations to how much of the femoral nerve you get in the fascia iliaca block, as well as how much local anesthetic you're giving and how high up you're going when you get this. So I don't really give many fascia iliaca blocks in the pain office. When patients come in with hip pain, I usually do a hip steroid injection. We are doing nerve blocks to the articular branches in the hopes to do a radiofrequency ablation, because I'm treating the pain chronically in patients who don't want surgery. But if you're in the emergency room, I'd say the fascia iliaca block you could probably do with, if you don't have an ultrasound, with the technique I described, but you have to be very careful with the amount of local you're giving. Make sure you monitor the patient. Or if you do have an ultrasound, possibly you could really do either. I mean, when we did the study where we would do both, the patients got relief with both. So I'm not sure if it really makes much of a difference. Definitely, if there's a fracture and lateral symptoms, I would go for the fascia iliaca, because you're more likely to get the lateral branches. Okay, so the saphenous nerve runs with the blood vessels, the artery vein, in the adductor canal, under the sartorius muscle, and above vastus medialis muscle. It follows the path. It's purely sensory. I mentioned that, just like the superficial cervical plexus. And you start above the knee in the anterior medial aspect of the lower thigh, and you're going to just scan back and forth to find your target. So this is where I would put the probe. Here's what it looks like in the adductor canal. You have the artery next to the nerve. It's a pretty easy shot to do. I definitely would recommend it for someone who comes in with knee pathology. It's a single shot, and you're getting a lot of relief for the distal for the distal thigh or the knee. Maybe give only, I don't know, 3 to 8 mLs of injectate. You don't need to really give too much. And the depth varies depending on how big the patient is. I think 2 to 4 centimeters is reasonable. Here's what it looks like with the needle in place and injecting. There's local anesthetic above the nerve. The sartorius is above the nerve. Okay, the sacral plexus originates from L4 to S3, and it's located below the sacrum. It gives rise to 5 distal nerves: the superior gluteal nerve and inferior gluteal nerve, the pudendal nerve, posterior femoral nerve, which is also known as the inferior cluneal nerve, and the sciatic nerve. Out of all these nerves, I think the sciatic nerve and maybe the pudendal is the most relevant for my practice and probably yours. The nerve, once again, originates in the plexus from L4 to S3, enters the gluteal region through the greater sciatic foramen between 2 muscle planes, the obturator internus and the inferior gemellus muscles. Posteriorly, you have the gluteus maximus muscle, which is more superficial to the nerve, as well as the piriformis. Piriformis is an external hip rotator on the the greater trochanter to the anterior sacrum is the insertion, and it lies right next to the nerve. When it's inflamed, it can trigger sciatica. When there's muscle spasm, it can impinge on the sciatic nerve. There are variants in which the sciatic nerve runs through the piriformis muscle. So sometimes patients will present with sciatica. It's actually a piriformis syndrome where the piriformis muscle is irritating the sciatic nerve, causing pain down the leg. Patient may have buttock pain down the leg, L5-S1 disc herniation, positive straight leg raise, which is basically a maneuver we do just to trigger the sciatica symptoms in patients with possible radiculopathy by stretching the nerve. And the thing is, patients have gone on to get surgery because they had a positive L5-S1 disc herniation, but they don't get better. And then they treat the piriformis syndrome with physical therapy or injection, and they get better. So it can be a real misleading thing. Just because somebody has a disc herniation doesn't mean that they're presenting with sciatica because of that disc herniation. If you scan 60 patients 60 years old and above, a majority of them will have disc herniations, even if they're asymptomatic. So just keep that in mind. The pain arises not just from the impingement, it arises from inflammation, right? I'm pinching a nerve, I'm squeezing a nerve right now, and I have no symptoms. But if I did this every day, all day, there would be inflammation. And that's what's going on in the back of a lot of these patients. So don't be fooled by the MRIs. And in the emergency room, I don't imagine you're evaluating many EMGs, so I wouldn't really focus on that today. So the sciatic nerve block is really important because patients come to the ER with sciatica pain, whether it's from a disc herniation or a piriformis or some other region. If they have sensitivity or tenels in the buttocks over the gluteal sciatic nerve, they may be amenable to sciatic nerve block, and you can alleviate the pain and get them home without having to be in the hospital and admitted. I know in my hospital, and it's not, I have some ER docs from my hospital listening to this. We get patients sometimes admitted for these problems, and the pain docs are not always in the hospital or available to treat it. So patients can sit on the floor for days after surgery has to evaluate them, after they get worked up with imaging. So ideally for patients, especially in the COVID era, to not need to get admitted for a nerve block, just to get something in the ER that would help them and then get triaged to an outpatient specialist would be ideal for the patients, especially to minimize opiates and avoid exposure to COVID. So if you have trouble identifying the sciatic nerve in the gluteal region, I recommend looking in the subgluteal region where it's more superficial, usually within 5 centimeters from the skin. It can be blocked more easily. The sciatic nerve has different appearances based on how you angle the probe. It could be flat, it could be oval. Here you have the needle going through the gluteal muscle. That's a sciatic nerve with local anesthetic spread. Here's another image of that. You could use a curved 5 to 7 megahertz low frequency transducer to visualize deeper structures better. I still do it with my high frequency in most patients. I see it fine. Patient is usually in the lateral decubitus position or semi-prone with the side to be blocked is on the upper side and the hip and knee flexed. You're bringing the hip and the knee to the patient's chest to reduce the distance between the skin and the nerve, and you're using bony landmarks, the greater trochanter of the femur laterally and the ischial tuberosity medially. So we have a question. How do I distinguish from sciatica from piriformis syndrome? Does it make a difference in terms of the decision in the ER whether to perform this complication specific to the block? Great question. Okay, so in terms of distinguishing sciatica from piriformis syndrome, the piriformis syndrome can be diagnosed through a few maneuvers. One would be a fair maneuver, which is flexion, adduction, internal rotation. So you're lifting the patient's knee. I don't know if you see this, maybe if I stand up, and you're lifting their knee up, and you're going to adduct and you're going to internally rotate. So you're going to take their foot outwards while they're lying on their side, and that's stretching the piriformis muscle, and that can reproduce pain down the leg. Of course, if they have a hip problem, which can also be a mimicker, you're going to get symptoms as well. They will also have tenderness over the piriformis muscle, and sometimes they may have sciatica or sciatic nerve irritation will also have tenderness in that region, and it is very difficult to tell. In my practice, I basically will do the sciatic nerve block, regardless of if it's sciatica from irritation down there or from the piriformis, because what happens is the piriformis is irritating the sciatic nerve either way. So I just go for the nerve to terminate the symptoms if the pain is going down the leg. The bigger question is, how do you know it's coming from? If the sciatica is a term for just buttock pain or back pain down the leg. Sciatica could still be from a disc. It could also be from something in the tush. So whether you want to know if it's radicular pain versus a piriformis syndrome, well, then I'll start to try to exacerbate or trigger something in the back. You could do, if it's a foraminal stenosis you're suspecting causing it, you might want to do axial loading, have the patient extend their back twist, which typically will be positive for facet joint problems in the back. And when I say facet joints, just so you guys remember what we're talking about, that's these joints right here, right? So when you're going backwards and twisting, you're stressing those joints, but you may also be closing the foramen. Now, if a patient will bend forward and they'll have pain down the leg, that's more indicative of a patient who has a disc causing sciatica, a discogenic pain. In addition, if the patient has a positive straight leg raise, it may point more towards a radicular symptom. So it's sometimes you get fooled. Even I've been doing this for 14, 15 years, and I still get fooled sometimes. So, but that being said, you're in the ER, you're not deciding whether or not to operate, right? Patients, if they have no nerve deficits, do not need to get emergency surgery typically, unless there's such a bad compromise of the cord or canal. But generally speaking, just for pain, if a patient's never had any interventional pain problems, no matter how bad the pain is, typically they don't need to have surgery for that pain. Surgery is a last resort, right? It's definitely not emergent. So if you're in the emergency room and you do suspect a disc herniation or a sciatica or a piriformis, if you could get the patient to ambulate to go home, I don't think they need to be admitted unless the pain is not controlled, maybe. So if you could control the symptoms long enough to them to get out of the office and follow up with someone like me, then you could help them. So how do you do that? When you're doing a sciatic nerve block, the biggest problem is not, I mean, if you know what you're doing, the biggest problem is not stabbing the nerve and causing infection, bleeding, nerve damage. The biggest problem is if you give them a good sciatic nerve block, they're going to trip on their way out of the ER and probably have more problems than they came in with. So when I do my consent, I tell the patients, A, you need someone to bring you home. You can't drive. You need someone to walk you home. The biggest risk for this procedure is you're not going to move your leg properly or feel the ground properly, and you're going to trip and fall. So the way I do this is with an injectate of dilute anesthetic and steroid that I've never seen a nerve motor or sensory deficit. I've been able to get the pain relief, which typically will occur before motor deficit, but without actually having problems that have ever led to the patient to fall. The patients I have who get repeat sciatic nerve blocks laugh at me when I tell them they can fall after the shot, because they're like, how can I never get any numbness? I don't know what you're talking about. So I'll give you the recipe in a second, but just to go back to identifying the nerve, it's about 1 centimeter or 2 in width and can be less than 3 centimeters below the surface or much deeper, depends on the patient. Hyperechoic, elliptical in shape, deep to the distal gluteus maximus muscle, and lateral to the biceps femoris muscle lower down. And it's usually has a well-defined aponeurosis. Here it looks a little triangular in shape. And you could use the greater trochanter, the ischial tuberosity as your borders or your landmarks, as well as borders. So you could go transgluteal or subgluteal. Subgluteal will be basically below the butt cheek. And it really depends on your skill set and what you're trying to achieve. So just some tips. Less gain to image is better than more gain. Okay. The less gain will make it darker, by the way. And the survey pattern should always be like the same I guess order of things, just so you can get used to where you're going. First, you can start with the ischial tuberosity or the bone you sit on, and then you can scan more lateral to get to the greater trochanter, and then look between them, and you'll get the actual nerve, hopefully. And if you can't find it, go to the subgluteal space, it may be more obvious. Here I have a picture of the focus points. The focus points are points that you can adjust on some ultrasound machines, and they give you the level at which the beams are most concentrated, so you can really get the best picture. Here there's two focus points pointing to them. Those focus points can be increased or decreased depending, and you want to focus basically where the depth is. So here I have an image of the ultrasound and the SIPP bone, or the ischial tuberosity, and the nerve is just lateral to it, going down the leg and bifurcating above the popliteal fossa. You want to make sure that you're scanning the appropriate depth and that your focus is at the appropriate depth. And repositions the patient's leg if you can't find it. Some patients can't lie with their hip and knee flex, but hopefully they can be. You can adjust to screen, as I mentioned earlier. There's all sorts of controls and frequencies that you can change to make it, and you have to play with your machine because of all machines are different. Some machines have a nerve preset or musculoskeletal MSK preset, which you could go on. And, you know, this is one of those blocks I'm not recommending you just do. This is something you need to be trained in at a course or with a doctor who's done these before. So if you're doing them in the ER, find a doctor who's done them before. So first, find the greater trochanter. This is a place where you have a lot of tendons inserted on the greater trochanter. And we'll talk a little bit more about this later. You have a bursa on top of it, which can get inflamed. But for now, we're just talking about identifying it. And then you're going to slide your probe more medial and find the ischial tuberosity, which, as you notice, the bones are always hyperechoic with a dark shadow behind them. Then you're going to go between the spaces. Sorry, going backwards. And you're going to scan between them to find the nerve which runs between them. Okay, so I have a video to show you about that, but just to get into my standard recipe of what I would use to do this nerve block and let someone walk out of my office without giving them a full-on motor block. Remember, even with this recipe, that block is possible. So you need to observe the patient before they get up, while they get up, and tell them they may not have numbness right now, but it could take an hour until they feel something. Sometimes in the sciatic nerve, the onset is prolonged, especially in the popliteal fossa. It could take 40 to 60 minutes for the block to take. So I usually dilute 4 milliliters of normal saline with 4 milliliters of 0.25% bupivacaine, add 4 milligrams of dexamethasone or depomedrol. The difference between dexamethasone and depomedrol is methylprednisolone. It's similar to Kenalog, I guess. They're particulate steroids, meaning there's particles, white little particles that stay in the area you inject it. It's more commonly injected in the spine and knees because they stay there for a while and hopefully will help reduce inflammation over time. The downside to it is if you inject depomedrol in a blood vessel, it can embolize. And there are cases of cervical transforaminal injections where we're sticking the needles into the foramen and they're getting into the blood vessels and they cause quadriplegia or other nerve deficits and stroke, spinal stroke. So remember, if possible, use dexamethasone for a lot of these procedures. I don't think many people use it for joints. If you're injecting a joint, I would just use depomedrol. So here's a little video about the sciatic nerve block. Use it for sciatica. Okay, lateral decupus position. There's a nerve. Here it's kind of oval-like. There's my needle. Okay, piriformis is actually a little bit above with the nerve. Okay. So the popliteal sciatic nerve block. I remember being in the Bellevue ER and we had some guy come in. He tried to hold an elevator with his foot and his foot got basically chopped off. Something I never thought could happen, but it happened. He came into the ER screaming his head off, begging to be put to sleep, which me as an anesthesiology resident at the time, I gladly did. We bolused him with propofol, SOX rapid sequence intubation. Now, I'm not saying that nerve block would take away the need for that, especially if he's going straight to the OR, right? Because but you might be able to take away some of the pain so that you get hemostasis and then figure out what to do with him, and he'll hopefully be more calm. But either way, this may have helped him, given with the state he was in, it might have been hard to position him because he was basically freaking out. Tibial nerve, peroneal nerve are the two branches of the sciatic nerve after bifurcation in the popliteal space. This usually occurs about 8 to 10 centimeters above the crease of the knee. The medial portion of the lower leg receives innervation from the femoral nerve, as we showed in the picture at the beginning of the talk, and that's via the saphenous nerve, right? The rest of the lower extremity is the tibial and peroneal or the sciatic nerve. So if you're doing an ankle procedure or you're doing, somebody fractures their ankle and you want to give them a nerve block for analgesia, you're going to do a popliteal nerve block with a saphenous or femoral nerve block. So a sciatic and femoral, getting branches of both those nerves will cover the lower extremity. And this is the region we're talking about, right? We're talking about the posterior and lateral and actually anterior aspect of the foot. You're not getting the medial aspect because that's saphenous. I use this nerve block for peripheral nerve stimulation and trials for patients who've had trauma down there and chronic neuralgia or pain or chronic orthopedic issues or tendinopathies, not responding to basic conservative care. I use it for neuralgia or foot pain of almost any reason. So the tibial nerve blocks more medial, the peroneal nerve blocks more lateral. You can use a 7 megahertz probe or even higher. I like the high frequency probe for this region. The sciatic nerve is often hyperechoic and round. It's posterior to the femur, lateral to the popliteal artery, and deep or anterior to the semitendinosus and semimembranosus muscles, medially, and the biceps femoris muscle laterally. More distally, the peroneal nerve may be followed as far lateral as the head of the fibula, which is an entrapment site. On the anesthesia boards, they ask all the time about the patient in prolonged lithotomy position. Lithotomy is the stirrups when your legs are up, and they wake up with a foot drop, and basically the peroneal nerve is lying between the stirrup and the fibular head, and therefore can be compressed. Okay, so semitendinosus muscle, biceps femoris muscle. Okay, so this is what it looks like right after it bifurcates, right? Beautiful picture with one of the older ultrasound probes, high frequency probes, but you see it's surrounded by local anesthetic, that's the black, and you can see the nerves with fascicles in them. I mean, this is a great picture of the tibial nerve, which is larger and more medial, and the common peroneal nerve, which is smaller and more lateral. Okay, this is the probe scanning the sciatic nerve, and this is how it bifurcates in the popliteal fossa. It becomes more superficial, and you see it bifurcating right now. Okay. And the tibial nerve is right by the artery, and the peroneal nerve is more lateral. Oh, sorry. Do that one more time. Okay, this is exactly behind the crease of the knee. So sometimes if you can't find the nerve as well, you could actually find behind the crease of the knee the two separate nerves and trace upwards to find the bifurcation where they join up. If you're going from down to up or distal to proximal. Okay, we have another question here. If they successfully do a nerve block, upper or lower extremity, or even trigger point, what do I recommend advice for getting back to activity? Some patients can't afford to see physical therapy or pain, or they just won't. And stretching, okay, how long before you recommend some stretching, trigger point, pressure therapy, myofascial release after performing this? if they're going home? Can they do more damage if they are numb? Okay, so in the ER, based on the doses I'm giving you right now, I'm not giving you such crazy doses that patients will be so numb for so long. Let me start off by answering the first part of your question. In terms of getting back to activity, it really depends on the pathology. I would recommend that most patients with a chronic pain problem do physical therapy. They usually start that for the most part, and this really goes more for spine procedures. I tell them 3 to 7 days after an epidural or a procedure. But if you're doing, let's say, a shoulder injection or a nerve block for frozen shoulder, you might want them going as soon as they get numb, for someone to kind of do some range of motion to get to break up the adhesions. So it varies. If they can't afford to see some, I think, in this day and age with telehealth, I'm sure there's probably some specialists who would do a telehealth consultation maybe for cheaper, or maybe they can work something out. I know that's an ongoing problem with a lot of pain practices. My practice doesn't accept every insurance, so sometimes we have that issue with the emergency room. As well as stretching, trigger point release, myofascial. Well, stretching is usually okay as long as there's no fractures. I don't think light stretching is not a problem. If you're really numb, you can do more damage. I'd say the biggest damage is really just like tripping and falling, not so much moving in such a way. Some people feel so good that they start going crazy and doing heavy duty work, or go bowling, or do something like, play sports they shouldn't be doing. And that could definitely do more damage. The numbness doesn't last more than a few hours typically, even if you use a steroid. The pain relief could last days to weeks. But I mean, they definitely need follow-up. I would just say either see a pain doctor, or if they can't follow up with a pain doctor, they should go back to their primary care doctor who could help them either find a physical therapist or pain doctor who will accept their plan. Most patients, even with Medicaid, can find a pain doctor. It's just in their book. They have to look it up. If the patients are just not really proactive, or from maybe it's a language barrier, then hopefully there's a family member that could help out. But yeah, you have to have a lot of precautions with these nerve blocks. As I mentioned earlier on, local anesthetic toxicity. You have to consider the duration, the time. You have to warn the patient. I mean, the suprascapular block, generally the arm will be weak for a few hours. I've had one patient call me 24 hours later freaking out that her arm was still weak, and that resolved. But some patients just don't read the textbooks, and their nerve block lasts longer than others. Okay, the genicular nerve block. This is really something that is a little higher level, but I mean, if you're really comfortable with these blocks in the emergency room, it's good to understand, because they're very popular with outpatient pain practices now, because you're blocking the nerves that innervate the knee without getting any motor. I used to do the saphenous blocks until I discovered the genicular. The geniculars were actually burning these nerves, we're neuromodulating them, putting wires on them, we're icing them with cryotherapy devices, we're doing all sorts of crazy things to these nerves. But the funny thing is, you don't sometimes even need to do that. Sometimes just lidocaine will give months to years of pain relief. I've cured people with lidocaine 2% without even giving any steroid. And there's a number of reasons for that. Some patients have adhesions, they have a lot of windup, and they just need to have some innervation blocked to the area. Patients who come back after knee replacement with swelling, they do really well if you add a local anesthetic and steroid to the genicular blocks, because you're reducing the inflammation in that area, hence improving the lymphatic drainage from the distal leg. And therefore, after this nerve block, sometimes the calf and the foot swelling will go down. So you can do a lot of good with these nerve blocks. But there's disagreement in the literature as to the origins of the genicular nerves. Some say that they come from the tibial, peroneal. Others will say they're branches of the femoral nerves. I'm not going to get too into that right now, but I just want to show you the basics. So there's 3 genicular nerves that are commonly targeted. There are actually more genicular nerves, but the superior medial, the superior lateral above the epicondyles of the knee, and the inferior medial nerves are the ones we go for. From a lateral view, you have the superior medial. They run with blood vessels, and the inferior medial. When you use an X-ray machine, this is where you target them. This is actually the traditional way of targeting them, going towards the epiphysis and the epicondyle. But the newer way is where I put diamonds, which is actually going to the corner, because the nerve is more superficial here and easier to get. So under ultrasound, which may be more relevant for us, you're looking for a blood vessel, a pulsatile blood vessel next to the nerve. And this is great for a patient who's a brittle diabetic and you don't want to give any steroid with, and you want to give them a good nerve block and get them out of the emergency room. Or maybe they had a knee replacement and there's no need to inject, but their knee is killing them. Or maybe they failed steroid, they failed viscosupplement, and they're just miserable in knee pain, or they fractured their patella or something. This could all help. So here's what the nerve looks like. It's very hard to see because they're very small, but they run next to the artery, they're hyperlucent. And the nerve of the artery may not appear as a circle or a long line. It's tortuous, the course. So it could have almost any appearance. Here's the nerve again. This is superior lateral genicular nerve, and the femur is the hyperlucent structure under the bony shadow. The nerve here is basically, I'd say it's underneath that blood vessel. And here's a little video of me doing this in the office. We're going to do a genicular nerve block. There are three branches: the superior medial, superior lateral, and inferior medial branch. Looking for the superior medial genicular nerve, I scan the medial side of the knee, putting on color Doppler, along with the artery, close to the epicondyle. Take off the Doppler, and one can see the nerve next to the artery. Scanning distally, the nerve approaches the corner of the epicondyle with the blood vessel. As it descends to innervate the knee. Low pinch, okay. Causing 1 to 2 mLs around the genicular nerve. Pivoting 0.25%. Now we're going to target the inferior branch of the medial genicular nerve, going below the knee joint onto the tibia, the medial aspect, looking for the blood vessel. It's a small nerve here, may be difficult to find at times. And it runs with a blood vessel and superficial to the bone. It appears that the nerve is right here. Take off my Doppler. Low pinch. Injecting another 1 to 2 mLs around the genicular nerve in the inferior medial position. The bone over here is the tibia. Now we're going to scan for the lateral branch, which also runs with a blood vessel. So I'm going to put my Doppler on as I scan for the blood vessel to help me isolate the nerve. And I like to go as distal as possible on the epicondyle as I'm scanning proximal to distal. I'm looking for the nerve in the blood vessel. Too much pressure and the blood vessel will disappear, so it's important not to press too hard. But I found the artery, and the nerve is right under it. There we go. There's a picture of it. Top of the artery, and I'm going to get the needle slightly lower to anesthetize the nerve underneath it. There we go. That's it. That's the nerve right above my needle. The arteries to the left of it. Much easier to see after the local anesthetic has been given. Okay, so you guys get the idea with that. Just a couple of things to say about that video. That patient was very stoic. This shot can hurt, okay? Make sure that you give good, I don't usually infiltrate skin wheel with this because I'm using a 25 gauge needle. Sometimes it actually hurts the patient more. I just stab the patient with the needle 25 gauge because it's the same gauge and you're not distending any tissue more superficially. But I do spray them with a vapor coolant spray, which helps. The other thing is, there is a lateral inferior genicular branch, but it's close to the peroneal, so we don't block it because if you get any damage there, you could cause a foot drop. So we don't recommend doing that. And this is really more of a cutting edge pain procedure done in the office, but there may be situations where you have that you can't or don't want to do a knee injection. You could also do a femoral nerve block, I suppose, but if you don't want to get the motor, you can opt for this. I would advise caution if you're doing a patient who's had a knee replacement, because if you get it infected, you're going to have a lot of problems between the patient and the surgeon. And I do this on patients who've had their knee replaced. I'll usually prep them with chlorhexidine and very sterile technique, but it's very, very useful for those patients who've had knee replacements and they're still in pain. Here's another great procedure called the IPAC block, which this one, I don't think it has its own CPT code. It's one of those unlisted codes. So you might need to figure out a way to talk to your coders on how to get paid on this one if you do it. This is called IPAC infiltration between the popliteal artery and the posterior capsule of the knee. So basically, it's for posterior capsule pain. So let's say the patient has a Baker cyst that's extremely tender, or the back of the knee hurts for some reason. Okay, you're not getting the tibial nerve so much, you're getting the capsule. And this shot works fantastically well without any very little risk of motor block. So here I'm using my ultrasound to visualize the posterior fossa of the knee. The tibial artery is next to the tibial nerve. I'm sorry, popliteal artery is next to the tibial nerve, and the needle's deep to that. The posterior capsule knee is all the way at the bottom, and there's my needle. And I'm giving maybe 5 or 6 mLs of 40% bupivacaine with a little steroid, and this works really well because a lot of patients will have posterior capsule knee pain after genicular blocks or steroid or visco supplements, and not many people do much for them. Really, there's not a lot that people do for this aside from the injections and surgery. So this is another way to do it. Foot and ankle, there's a lot of nerves to block down here. Peroneal, saphenous, superficial peroneal, deep peroneal, and the tibial nerves. As anesthesiologists, we do something called an ankle block, which is where we basically do the whole foot. We get anesthetized for maybe an amputation or some other foot surgery. We'll block all of these nerves. The saphenous nerve block is the medial aspect of the lower leg, and it's a very small nerve next to the artery. Okay, we're really superficial here. We're not even a centimeter depth with the ultrasound probe. So you have to be very careful. When you inject around here, around the ankle, you're not just getting the nerve, you're getting everything in that plane. You may be getting the tendons as well. It's just because they're so packed in together. The superficial peroneal nerve and sural nerves are noted here. The peroneal nerves getting the top of the foot. The deep peroneal nerve gets the web space between the first and second digits. And the tibial nerve gets the bottom of the foot. So here's what it looks like under ultrasound. Okay, so you have to the left anterior and to the right posterior. So you have the Achilles tendon. You're looking from a lateral posterior view, and you're seeing the small saphenous vein running next to the sural nerve. Once again, the sural nerve, once again, it's a similar view, just the foot's turned. Okay, look for it next to the small saphenous vein anterior to the Achilles tendon. Tibial nerve is an important one. Okay, it runs in the tarsal tunnel. It comes all the way down from the popliteal fossa. So here we're scanning for it. And it's next to the artery. Tibial nerve is next to the tibial artery. And you have here the flexor digitorum longus and the flexor hallucis muscle. Okay, as we run up with the ultrasound, we're following up the tibial nerve and artery. The tendons become muscles, and you could block the nerve at any point, at the ankle, at the foot, or above. In my diabetics, I choose to go more proximal. I don't want to give them any ulcers. And here you have the muscles on ultrasound labeled. The nerve is right there. Okay. So we're just watching it go up again, in case you missed it the first time, and you see how the tibial nerve runs with the artery. Okay, deep peroneal nerve goes to that web space between the first and second digit, and it's on top of the bone next to the anterior tibial artery at the ankle. These blocks don't require a lot of anesthesia. You give 1 or 2 mLs of 40% bupivacaine. Good in case somebody comes in and you need to suture their foot or do something else on their foot. Superficial peroneal nerve, just scanning down on the ankle. Okay, you see it's above the bone, whereas the deep one is on top of the is right on top of the bone with the artery. Tarsal tunnel syndrome. So the tarsal tunnel is it's like the carpal tunnel of the foot, more or less. You can have a neuropathy with compression of the tibial nerve and its branches. You have the medial plantar nerve, the lateral plantar nerve, the calcaneal branch. There's variable anatomy, and it may arise from proximal or distal to the flexor retinaculum. So if you see here, pain at the bottom of the foot is often from a branch of the tibial nerve. You have a little bit of the sural and saphenous nerves, lateral and medial, respectively. But a good part of this is the tibial nerve branches. You get compression of the nerve, and when they do a surgical decompression, you may have a missed branch because not every branch will run through the flexor retinaculum. So if they don't get the proper branch when they do surgery, you're not going to get relief of your symptoms. MRI would be the gold standard if you're suspecting a space-occupying lesion. Otherwise, you can make the diagnosis with ultrasound or EMG. There'd be increased duration of motor conduction, reduced amplitude of the tibial nerve. Treatment, NSAIDs, custom orthotics, physical therapy, injection, surgery. I mean, if they come to the ER with pain over there, if you want to do this nerve block, if you're confident in your skills, you just do it and send them to a podiatrist or a pain specialist to evaluate them, or a physiatrist, neurologist, depending on their symptoms, of course. So there's the tibial nerve. Okay, so now it's time for a break. But before we go on our break, I wanted to know if there's any questions. Okay, so up next is the soft tissue and joint. Let's resume at 12:35. Thank you. Okay. So a lot of patients will come to the ER for orthopedic problems, and sometimes you guys, I'm sure, will be faced with them, and I'm sure you've already experienced it. First, the question really is diagnosis. You guys are limited in your abilities at times because you don't have a full consultation note, MRI, et cetera, imaging. So you really need to rely on your clinical exam and maybe some basic imaging like X-ray. So a patient who presents with biceps tendonitis will typically have pain in the anterior shoulder if it's a proximal biceps, or distal arm if it's the distal biceps tendon above the elbow or at the elbow. So the tendinopathy is exacerbated, of course, by any sort of movement of the muscle or the tendon. And oftentimes palpating the biceps tendon can give you a clue that there might be something going on. And you can also find pathology on the ultrasound. Now, this is not a diagnostic lecture. There are ways to diagnose the pathology under ultrasound. I'm not going to focus too much on that. This is mainly just helping you identify it and guide the needle towards the structure. So here you see the ultrasound is scanning upwards on the biceps tendon. And as we get higher, the long head of the biceps tendon is forming. It's hyperlucent because it's more dense than the actual muscle. And as we get higher up, it's going to form in the groove of the humerus, in the bicipital groove, which you'll see a little clearer over here. Okay, here we have the biceps tendon cross section and the subscapularis muscle coming across. This is subscapularis over here, and it comes across over the biceps tendon in the bicipital groove of the humerus. It's a cross section of the tendon here. And as you turn the probe, you can also get the longitudinal view of the tendon, and you can see the tendon fibers get longer, and you might find some anisotropy, which is basically some irregularities in the way the tendon looks based on the way the ultrasound crystals are aligning to it, but they don't necessarily mean pathology. Unlike here, where we actually do have pathology. If you see here is a biceps tendon, it's normal to have a little heterogeneity in this view. However, here you have fluid around the tendon, which is a sign of some sort of inflammation. Excuse me, I'll go back there. And the needle is coming towards the tendon to inject it. Typically, the needle will come from lateral to medial. I like to go in plane approach. Okay. You can use a 25 gauge 1.5 inch, or if it's a larger patient, a 3.5 inch needle to get the needle where it needs to be, and inject anywhere from 3 to 4 mLs of injectate consisting of 10 to 30 milligrams depomedrol, bupivacaine 3 to 4 milliliters. I typically will give 20 milligrams of depomedrol mixed with bupivacaine. Keep in mind, anytime you're injecting a steroid near a tendon, there's a risk of rupture. So don't inject into the tendon. You know that you're not in the tendon by visualizing your needle around the tendon and not in it. Also, it should be a smooth injection. If there's resistance, do not inject. Okay, so it's just a short video on the injection, or at least the placement of the needle. See, there's already fluid around the tendon before the needle even gets there. And carefully, I put the needle next to it. And this is where I would inject. Okay, the medication should infiltrate around the tendon. Now, here's just an image of the pronator window, which is how you see the distal tendon. Okay, you see the biceps tendon and the radial head and the brachial artery. And here we're actually imaging like this, and then we're going to show the muscle and tendon underneath and correlate everything. So your biceps tendon, and then the radial head. Now, this is something that might not look right to you. You need to play with this with an ultrasound. Nothing beats actually getting an ultrasound and experimenting on yourself and your colleagues just with the views, trying to figure things out, looking at the anatomy books or this lecture. Some of this may come natural for some of you, some of it may not. At the end of the day, it really just comes down to practice. Okay, the AC joint. This joint is intact with range of motion, except for cross-body adduction. Behind the back motions and overhead reaching can all produce pain if there's pathology of the acromioclavicular joint. Pain to the deltoid area may occur upon cross-body adduction, and has also been noted is likely caused by irritation of the underlying subacromial bursa by the inferior projecting osteophytes of the acromioclavicular joint in those patients who are arthritic. The differential diagnosis of acromioclavicular joint pathology includes calcific tendinosis, glenohumeral joint arthritis, adhesive capsulitis, and rotator cuff impingement. On exam, the acromioclavicular joint, which you can find by just running your finger between the acromion and the clavicle right over here, it can be tender. Okay, and you see here on the imaging, that's where the joint is at the bottom right. Pain can be elicited by motion of forward flexion of 90 degrees with horizontal adduction, crossover test, or straight ahead pushing as in a bench press can also cause pain. So this is what it looks like under ultrasound. Pretty clear. It's very superficial. I'd say the most difficult thing about this is actually getting your needle in the joint under ultrasound, because that big probe can block your way. So you might need to go either out of plane or be a little creative with how you angle the ultrasound, maybe even go like this to go in plane. And here I have on the next slide, I believe, yeah, here's an image of doing that. So you're finding the leftmost is the acromioclavicular, is a clavicle. We're moving over it to get to the spot where this bone disappears, and that's the joint. That's the actual joint right here. Okay, that's where you would inject. And then it's a very small joint, so you have to just make sure that you're between the bone. Trigger finger. This is something I commonly see in the office. I don't know if anybody goes to the emergency room for this, but I would imagine they do if they don't have insurance or if they don't really know where to go. And if it happens and they get really scared because they can't move their finger, it's basically catching of the thickened flexor tendon in the distal palm with abnormal gliding and locking of the tendon within the sheath. The tendon gets caught on the edge of the first annular pulley, which is about over here, and catching occurs during active flexion. There's a stiff, tender, palpable nodule. It's associated with rheumatoid arthritis and gout. There's no real lab tests. You may want to rule out a rheumatoid factor or check the hemoglobin A1C or fasting glucose, because there may be a higher incidence in patients with diabetes or rheumatoid arthritis. X-ray is usually not indicated. You may want to get it if you suspect something else going on, or to look at, you may see loose bodies in the MCP joint, spurs at the metacarpal heads, or avulsion injury of the collateral ligaments. So this is what the tendons look like under ultrasound longitudinal view. Okay, I'm looking at the flexor digitorum superficialis, more superficial, and the profundus tendons underneath it. First line treatment is a steroid injection. CPT code is 20550 7692 for the ultrasound read. Less commonly, there's custom splints that you could use that hold the joint at 10 to 15 degrees flexion, leaving the PIP and DIP joints free to move. Surgery, some of the literature says that if you fail 2 injections, it's an indication for surgery. And what they do is they release the A1 pulley. Here's a cross section of the tendons, and there's an effusion around the tendons. It's fluid, and that can be a sign of pathology. Here is the cross section versus the transverse in plane view versus the cross section. You see the metacarpal bones are deep to everything here. Now, the trickiest thing with the shot is getting your needle in It's a small area with a big probe. So there's an advantage to doing the cross-section approach because you could see the tendon really well, but it's hard to get that angle of that needle into the tendon sheath without getting the tendon. Alternatively, in-plane approach longitudinally could also be nice. However, there's not a lot of room to work, so it could be a little challenging. Sometimes out of plane may be best, but you have to be really experienced with out of plane before you do it because you don't want to inject in the tendon. I don't give a lot of volume, 1 or 2 mLs with maybe a 1/4% bupivacaine with 10 to 20 milligrams dexamethasone should be all you need. You may even feel the tendon sheath get distended like a balloon blowing up after you inject from the fluid. Like I said, out of plane may be necessary. Patients typically feel better within minutes. It may take some time for the swelling to go down for them to move their finger better, but the pain usually gets better because you may also be blocking the nerves for the digits and tendons. So this decurvainous tenosynovitis is a thickening and accumulation of mucopolysaccharide in the sheath of the abductor pollicis longus tendon, the extensor pollicis brevis tendon. The extensor retinaculum is a fibrous band attached to the radius and prevents bowstringing of the extensor tendons off of the dorsum of the wrist. Okay. Symptoms, pain can be at the base of the thumb, swelling near the base of the thumb, difficulty moving the thumb and wrist when grasping or pinching during activities. There could be a sticking, stop and go sensation in your thumb. Positive Finkelstein's test can occur. The examiner grabs the thumb and ulnar deviates the hand sharply. If the wrist pain occurs along the distal radius, the top of the forearm, when you close the wrist, it's most likely positive for decurvainous. And then you have Eichhoff's test in which you're taking the thumb with the fist, okay? And then you're doing an ulnar deviation with the thumb held in the fist. And if sharp pain occurs at the distal radius, decurvainous is suspected, but this is more likely to produce false positives, this test, than the Finkelstein's test. So most people do Finkelstein. Risk factors: repetitive movements, pregnancy, trauma, rheumatic disease. The differential is osteoarthritis of the carpal metacarpal joint, the ganglia, Wartenberg syndrome, and infectious tenosynovitis. Wartenberg syndrome is entrapment of the mononeuropathy of the superficial branch of the radial nerve. It presents as numbness, tingling, weakness of the posterior aspect of the thumb. So the treatment includes NSAIDs, immobilizing splint, physical therapy, occupational therapy, TENS, steroid injections, or surgery if there's risk to the radial sensory nerves. Okay, so in this stenosing tenosynovitis, you could see here the tendons laid out, the adductor pollicis longus, the extensive pollicis brevis, they're both in a sheath. The radial artery is next to them, the radial bone. You can scan the radial aspect of the wrist. You're looking for the extensor brevis and adductor pollicis longus tendons because they share that tendon, that tendon sheath. Once again, repetitive movements can predispose to this. It is a superficial injection, and with steroid injections, you need to always be careful for skin atrophy, hypopigmentation that occurs with superficial injection of steroids. So here's a position of the ultrasound. Once again, the extensor pollicis brevis, abductor pollicis longus is a little harder to see here. There's more fluid around it probably. And you have a needle coming into the sheath, okay? And you're basically injecting from underneath the probe in plane. And you can even see the bevel of the needle here. That's how good you see the resolution. And this is a 25 gauge needle. It's not hyperechoic. It's not one of those echogenic needles. It's a regular needle. So once you get really good, you don't need some fancy, expensive, echoic needle. You could just use a regular needle to do these shots, but just be careful because those needles are sharper and you could predispose to damage if you're not careful. Okay, once again, adductor pollicis longus, extensor pollicis brevis. The radial nerve is here. Just hydrodissecting to get over to the tendons. So we're coming from this side, right? If we're seeing the radial nerve first, the needle's passing above the radial nerve to get to the target. Okay, lateral elbow pain can be for a variety of reasons. You have the extensor tendons, and they're affected with lateral epicondylitis, extensor of the hand, right? They insert on the epicondyle. The radial collateral ligament, which connects the bones, the radius and the humerus. The posterior interosseous nerve, which is a deep branch of the radial nerve, exits the radial tunnel and pierces the supinator, as the PIN for short. It's a motor nerve, excuse me, and it dives deep to the arcadophros. Okay, the ulnar collateral ligament here is depicted. Okay, on the picture, the drawing here, you also see tennis elbow, which is epicondylitis of the extensor muscles. And that's where you're putting your ultrasound to visualize this. So here on this image, you have above, you have the ligament, and I'm sorry, the tendons, and then below the ligament. Okay, cubital tunnel syndrome, we talked about this earlier. You have medial elbow pain, paresthesias D4, D5, weak grip strength, tunnels over the cubital tunnel. There's entrapment at the cubital tunnel or aponeurosis, and there may be an enlarged ultrasound view of the nerve. So the only nerve, once again, I'm mentioning again here because this is part of the soft tissue lecture, because the cubital tunnel is a soft tissue nerve entrapment. In the arm, the ulnar nerve lies between the axillary artery and vein in the axilla, and then it descends down. Here's a picture of the nerve. Okay, that's what it looks like when you're doing it in longitudinal view at the bottom right. And here's how the ultrasound is being held here. Okay, the last video you saw previously earlier today was when the probe was turned this way. Now it's over here, so you see the long view of the nerve. And here's that video again to appreciate the difference in how the nerve looks when you're coming in to inject it in a cross-section view. Okay, we also talk about the ulnar nerve distally in the arm, lateral epicondylitis. Here you're looking at the lateral epicondyle and the extensor tendons. Okay, so you have the tendons inserting on the epicondyle for the wrist extenders. You also have in lateral epicondylitis, which should be called tendinitis, right? It's not an epicondyle inflammation. It's really a tendinopathy. It's chronic symptomatic degeneration of the wrist extensor tendons involving the attachment of the lateral epicondyle to the humerus. Very chronic and common. 1 in 3% of the population, usually middle age, without gender predisposition. I have a lot of anesthesiologists and other doctors, surgeons at the hospital who come up to me with this problem all the time. Steroid injection helps, however, in my opinion, and according to the literature, PRP would be better, platelet-rich plasma, which we're doing a lot of in the office. Extensor carpi radialis brevis is the most commonly affected muscle, but the supinator and other wrist extensors, such as the extensor carpi radialis longus, extensor digitorum, extensor digiti minimi, and extensor carpi ulnaris can be involved. Any activity involving excessive repetitive use of these muscles, such as tennis, playing an instrument, typing, manual work, can cause the problem. Smoking and obesity have been risk factors as well. Okay, so treatment. Rest, modification of activities, that could give relief, physiotherapy. Some people use braces, NSAIDs, of course. People do corticosteroid injections. I do corticosteroid injections, but I prefer to do PRP because I think it's safer for the patient, less risk, and actually lasts longer. Percutaneous radiofrequency thermal treatment's been used. Extracorporeal shockwave therapy has been proposed as an alternative to non-operative management. The mechanism is not really known, but they put shockwaves over the tendons, and they found it to be more beneficial than many other modalities. There's some evidence that low-level laser therapy works as well because it helps stimulate collagen production. Acupuncture. So when they compared PRP to corticosteroids in the management of lateral epicondylitis, they found that there were superior outcomes for reducing pain and improving elbow joint function compared with local corticosteroid treatments for lateral epicondylitis at 6 months follow-up. And I got to tell you, when it comes to PRP, a lot of the data is coming back very similar for the most part. If I had to give it overall, of course, it varies from study to study, but for the most part, many of the studies that go over PRP versus steroids for many pain problems, not all, but many, sacroiliac joint, facet joints, will show that the PRP takes longer to work, but it lasts longer and it's probably safer. Okay, medial elbow pain could be the common flexor tendon, the ulnar collateral ligament, the ulnar nerve. Golfer's elbow, there's alteration of the muscocutaneous origin of the common flexor tendons. It's right here, right? Overuse possibly. This occurs in the 4th and 5th decades of life, but much lower incidence later on. There's greater association with occupations such as sports, and with forceful work being a greater risk factor alone than repetitive work. Usually, it's pronator tears and the flexor carpi radialis that are affected, but the medial epicondylitis can involve all the muscles of the flexor pronator group. Patients will typically have pain exacerbated by flexion of the wrist. Okay, you're flexing those flexors, and that's straining the tendon on the medial aspect of the epicondyle, which we see here. Okay, the ultrasound is positioned as such on the elbow. The trickiest thing for an injection here with the ultrasound is that sometimes there's not much room between the needle and the probe. Sometimes it's even easier to do this blind. The trick is do not inject in anything that is resistant. Okay, when there's medial elbow pain, you can have the ulnar collateral ligament causing problems. You see this in javelin throwers and pitchers. Probably more often in pitchers. I don't know many javelin throwers. Posterior elbow pain could be a triceps tendonitis. Here you're just looking at the triceps tendon in the long axis. Okay, that's above. And you have the humerus and the radius bones depicted on the left and right respectively. So the knee, here you have an image of the patellar tendon. Okay, pretty clear. You have the tibia on the right, the patella on the left, and that leads to the femur eventually. The ACL, I don't know if you could really appreciate this, but this kind of, where's my cursor here? Oh, there it is. Okay, for some reason my mouse disappears, but the ACL is kind of like a triangular structure going posteriorly as it ascends, and you could kind of make it out as a hyperlucency on this image. So there's a little knee injection.
So what we're doing is we're scanning in a longitudinal view the knee joint, and to the right of the screen you have here the femoral bone, and as you scan inferiorly you have the tibia. The space between is a joint space, and we're going to go slightly medial to the patella. I'm going to use an out-of-plane approach in which I won't see my whole needle. However, I'm getting the landmarks of the joint to avoid encountering bone on the injection. Okay, press save the camera. No, I meant, yeah, the movie film.
Now this is
Pinch.
the out of plane view. There's another video I have, which hopefully is here on the in plane view.
As you can see, there's fluid going into the joint. You can't really see the needle so well because it's an out of plane approach. However, we have a nice smooth injection.
You don't need an ultrasound to do this, but the advantage is you're less likely to encounter bone when you're sticking the needle in, and it's going to be less likely to hurt the patient. And it will hopefully expedite the treatment. Okay, so this is the in-plane view. So just turn the probe sideways.
Okay. Pinch.
Takes 2 seconds, right? Not a big deal. Okay, housemaid's knee. This is a very sexist term, but it's basically, let me go back to that. Bursitis of the patella. It's called a prepatellar bursitis. So there's just a bursa on top of the patella, which gets inflamed for people who tend to kneel too much. I guess like housemaids who are cleaning the floors. Sorry, ladies. The lateral collateral ligament. The ligament is depicted here. It sometimes gets damaged or inflamed. You can do PRP or steroid shots here. You have the femur on top, the fibula on the bottom. Iliotibial band syndrome, it's lateral knee pain, 1 to 2 centimeters above the lateral knee joint is typically where the pain is worse. It's worse with running downhill activities. The lateral synovial recess inflammation occurs from the ITB rubbing against the epicondyle. It can happen with limb length discrepancy, genovarum, overpronation, hip adductor weakness, and myofascial restriction. Here's a picture of the ultrasound scanning the band as we get closer to the knee. It's a superficial band that you have right here, more or less, the iliotibial band. And now we go back up. It changes the depth as you go down and up. So on the MRI, it's ill-defined signal abnormality in the fatty soft tissue interposed between the iliotibial band and the lateral femoral epicondyle. There's a low signal on T1 and high on T2, in keeping with edema and fluid. Now, I know you guys are not going to really be diagnosing this on MRI, so I just figured I'd mention that. But physical therapy, like everything else, physical therapy, anti-inflammatory, steroid injection, surgery. Differential diagnosis includes the meniscus tears, lateral collateral injury. Now, the hip joint, you may get patients with hip osteoarthritis in the ER. A hip x-ray and a physical exam could clue you into this. Hip x-ray would be degeneration of the joint space, lack of or loss of joint space, exam pain with hip flexion, internal, external rotation, tenderness to anterior palpation or posterior palpation of the hip joint, groin pain. Of course, you need to rule out fracture of the hip. So with the ultrasound, if I want to do a hip shot anteriorly, I typically will use the ultrasound. For some reason, I need to go posterior. It may be deep. I may wind up using an x-ray machine. You could do it under ultrasound, but I recommend doing the anterior approach. As long as you can avoid the femoral artery, the nerve, and the vein, then I don't see why you can't do an anterior hip joint injection and get relief even if the pain is posterior. Now, if you're having a tendinopathy of the hip and it's one of the tendons that's inflamed, well, you may not get relief with a hip joint injection. So you need to try to distinguish between tendinopathy of the hip versus arthritis of the hip. It may be a little challenging. You may need to get an MRI to do it. They don't respond to a joint injection. Or if the x-ray is normal and they still have pain in the hip or pain with motions of the hip, you might need to get that MRI to give you more results. But in the emergency room, you're limited with that, right? So you might need to just give them a hip shot to see if you can help them and get them out of there to see the orthopedist or the pain doctor. So here's this rectangle is really where I image the hip. I go for the neck of the femur to the head. And you're going really through the iliacosoas muscles / tendons to get to the hip. Here's an image of the iliacus muscle and tendon. Now, just as an FYI, we talked earlier about the fascia iliaca nerve block, and basically that was over here. The fascia iliaca is the femoral nerve. For some reason, my pointers wasn't working there. Let's see if I can get it here. Yeah, the pointer disappears, but basically you see the femoral nerve next to the femoral artery, but some of those hyperlucent white structures are going on top of the iliacus muscle, kind of above the arrow where it says femoral nerve. That's still femoral nerve fibers, that thickening, and that's underneath the fascia iliaca. So that's where we do the fascia iliaca block. At the bottom, you see the head of the femur, that hyperlucent bone with a capsule above it. So here's a hip injection video. So using a 25 gauge 3.5 inch spinal needle, in-plane ultrasound injection. Okay, we're imaging over this area. So the femoral neck, iliopsoas muscle, head of the femur, iliopsoas tendon, and I'm injecting probably 30 or 40 milligrams of depomedrol steroid with 3 or 4 mLs, 0.25% bupivacaine. And we're nowhere near the femoral artery and nerve. It's not even on the screen for the ultrasound. Okay, when we're injecting the hip joint, when we're injecting on the head or upper neck of the femur, we're not actually injecting in where it looks like the joint space, because it's hard to get that to that spot. You don't really need to. You're going to be in the capsule, and it should be enough to help the patient. Okay, Achilles problems. You have tendonitis, which is inflammation, tendinosis, which is just chronic cellular degeneration, and then you have tendon rupture. Okay, obviously Achilles tendon rupture is a really bad situation, and it could be, it's a surgical case. So to the greater trochanter of the hip, we talked about this earlier. We had this, this one seen. You have tendons such as the gluteus medius tendon inserting on the greater trochanter. So sometimes you have a hip tendinopathy, and you can get it by injecting either the bursa or the tendon as it inserts onto the trochanter. And these patients will present with tenderness of the bursa or pain upon movement of the hip or palpation of the gluteus medius tendon. Here's the Achilles tendon under ultrasound. Okay, cross section of that tendon is here. And the thing with the Achilles tendon is we don't want to inject it with steroids. Some people do. I've done it a long time ago. Now I just do PRP on it, and it works very well. It's a lot safer. If you pressurize or inject it into the tendon, whatever you're injecting, you could rupture it. I've seen the longest term pain relief when it comes to PRP injection. So here's the actual injection, a picture of me injecting the tendon. Here, the tendon's a little flatter. Doing it in plane approach. Okay, the tarsal tunnel syndrome we touched on before. It's a compression of the tibial nerve and the flexor retinaculum. Here's the tibial nerve, and let me go back so you can just look at that. So you have the blood vessels above it, and you're looking right where this ultrasound is, over the tunnel. The flexor retinaculum is above. The peroneal nerve can get tendon can get inflamed, and that will be pain on the lateral aspect of the foot or below the lateral malleolus. Okay, plantar fasciitis, very common problem. You can have a spur causing it, any sort of inflammation underneath the foot. Most common cause of heel pain. 40 to 50-year-olds, 2-to-1 female to male preponderance. Microscopic tears of the fascia, there's inflammation, fibrosis, myxoid degeneration, and degeneration of collagen tissue. Okay, so you have the calcaneus here. We're scanning the foot as you see in the picture. Plantar fascia is moving distally from there in that plane. And here's a video of a patient who is going to get a tibial nerve block for PRP injection of the plantar fascia. So this patient suffering from plantar fasciitis related to a heel spur, I'm going to give her a PRP injection, platelet-rich plasma, to reduce inflammation and promote healing. Prior to doing that, I'm going to give her a tibial nerve block to reduce the pain so that I don't need to put any local anesthetic with my PRP. I don't want anything to interfere with the activity of the PRP. So I'm going to go proximal to the tibial nerve, which innervates
the medial and inferior aspect of the foot, and will hopefully give her enough anesthesia for the procedure. So to find the tibial nerve, I'm locating the medial malleolus. I visualize the nerve next to the artery. And one option is to go towards the tarsal tunnel, which is over here. You have Tom, Dick, and Harry, tibialis posterior, followed by flexor digitorum, and then flexor hallucis longus. With the tibial nerve in between them. Another option is to go more proximal for the tibial nerve and follow it up in the ankle. So, to the right of the screen, we see the Achilles tendon. We're going to give her a little vapor-coolant spray for skin anesthesia. A little pinch. So as you see, here's my needle. It's surrounding the nerve. The black around the needle is the local anesthetic. Now we're going to image the plantar fascia. I put my probe underneath the calcaneus. The fat pad is the most superficial, followed by the beginning of the plantar fascia. As I scan distally, you see the fascia. I'm going to turn my probe transverse. And my point is anterior to the calcaneus. That's where I enter my needle, aiming towards the center of her foot. The plantar fascia is this layer right here. So now I'm going to insert the PRP, aiming for the plantar fascia. Little pinch, Regina.
Okay.
Feel that?
Very little.
Good. And you can see my needle entering into the fascia. I'm depositing the PRP superior to the fascia, as well as into the fascia. If there's resistance, I'm not injecting. And you may be a little sore here after, but it's going really well. Nice and smooth. This is
What? Ice.
this is the way it should feel. So basically, this patient underwent a tibial nerve block prior to the PRP injection. The PRP was injected into the plantar fascia, which can be a painful shot. The tibial nerve block alleviated the symptoms or the pain of the injection. The PRP is now on the plantar fascia. It may take a few days to weeks to work, but will hopefully give her pain relief superior to that of steroids.
Okay. Now I know you guys aren't doing PRP in the ER. That's not happening. However, you could use steroid and local anesthetic, and you can get patients out of pain and hopefully ambulating to go home and follow up with a pain doc or podiatrist, etc. So we could, it's 1:13 right now. We have 2 more segments. Let's do a short break and then we'll come back. Let's say about 1:20, we'll resume, okay? Okay, guys, I'm back. Are there any questions before we continue with the peripheral nerve blocks? Okay, so we'll move on. So starting with the genitofemoral nerve block, the nerve arises from the lumbar plexus, supplies the sensation of the skin in the anterior scrotal region in males, or the mons pubis in females, and the upper segment of the anterior thigh in males and females. It's the genital branch of the genitofemoral and the femoral branch. It's distinct from the femoral nerve, but the genitofemoral nerve originates from upper segments of the lumbar spine, L1 and L2. Here's an image of the testicular artery, the spermatic cord, and the pubic tubercle. I'm not sure how useful this is in the emergency room, but you may need to, at some point, provide anesthesia of this region. I would not recommend doing this during testicular torsion or anything like that. However, if there is any sort of injury to this region, you may be able to take care of some of the pain with the infiltration in this region. However, you need to be very careful because you don't want to cause damage to the ductus deferens or the blood vessels or the nerve in this area. So one of these, this might be one of those things that's good to know about, but you may never wind up doing. So the genitofemoral nerve descends inferiorly, piercing the psoas major muscle before emerging on the anterior surface, then traverses the retroperitoneum, descending over the anterior surface of the psoas muscle. Okay, here's what it looks like in real time with Doppler. The nerve continues inferiorly, ultimately separating into the two divisions, femoral and genital branches. And as it reaches the groin, it enters the deep inguinal ring and courses through the inguinal canal. Here's an image of the actual block, the needles coming into the sheath and depositing local. It's very hard to see which is the nerve in the region of the spermatic cord because of it's a lot of hyperlucence and honeycomb shaped. You see that more on the previous slide with the spermatic cord and whatnot, but it's in the general vicinity and the local will spread. So if you're not really sure, you should be able to get a decent block in this region. Okay, neuralgia paresthetica. Mononeuropathy of the lateral femoral cutaneous nerve. This can cause a lot of disability because it's often misdiagnosed and treatment can be delayed. There's dysesthesia or anesthesia in the distribution of the nerve, which is the anterior lateral or the lateral aspect of the femur, basically below the hip. Patients can have burning, coldness, lightning-like pain, deep muscle pain, aching, tingling, frank anesthesia, hair loss. It can mimic hip pain, radicular pain, iliotibial band, greatotrochanteric bursitis. The nerve is a sensory nerve mainly that includes efferent sympathetic fibers carrying vasomotor, pilomotor, and pseudomotor impulses. It has a variable origin, but L2 and L3, L1 and 2, and L2 or L3 alone have been found. It's associated with femoral nerve as it passes through the inguinal ligament or may anastomose with the femoral nerve distal to the inguinal ligament. On occasion, the lateral femoral cutaneous nerve is absent and may be replaced with a branch of the ilioinguinal nerve. And frequently it's found passing through the split lateral attachment of the inguinal ligament. As the nerve curves medially and inferiorly around the anterior superior iliac spine, it can be subjected to repetitive trauma in this fibrosing tunnel. So the cutaneous innervation of the lateral thigh is provided. It's a dorsal branches of L1 and L2, as I mentioned, it varies, and it passes under the inguinal ligament. It's 2 centimeters medial to the anterior superior iliac spine. Superficial to the sartorius, it divides below the sartorius muscle into the anterior and posterior branches. And then the nerve is superficial to the iliacus muscle between the fascia iliaca and the fascia lata. So here's an image. You're basically taking the ultrasound and looking down on the anterior superior iliac spine as such. And you can see the nerve in the corner on the top and the iliacus muscle. And by the way, you can see the fascia iliaca over here. It's once again, my cursor is not working on the screen for some reason, but it's basically on top of the iliacus muscle, the white hyperlucency, the thickening. Okay, once again, same thing, more or less, but you have the sartorius muscle here and the nerve is right next to it. And this is the orientation of the probe. Here's a nerve under the sartorius muscle. Okay, the peroneal nerve we discussed earlier, and we talked about the entrapment with the head of the fibula. And here in this picture, you could appreciate how superficial the nerve is and how that entrapment may occur, because that's the cross section of the fibula on a ultrasound view as such. And you see the orientation of the fibula to the nerve. Also be careful when you do this injection, make sure you see your needle because it's very superficial. You could easily stab the nerve and traumatize it. All right, this is a big one for you guys, the intercostal blocks. It's one of the oldest peripheral nerve blocks. The earliest description was 1907. They obviously did it blind. No fluoroscopy, no ultrasound available back then. Most of us usually inject local anesthetic with or without steroid. The nerve is right under the rib, and that's the target for the injection. You could use alcohol or phenol for cancer cases, or if you want to do a neurolysis. I have not really injected PRP or any regenerative medicine here. So the anatomy, you have 12 pairs of thoracic spinal nerves, T1 through 12, divided into ventral, dorsal, rami as they pass through the intervertebral foramen. The ventral rami of T1 through 11 forms the intercostal nerve that enters the intercostal space. The ventral ramus of T12 forms the subcostal nerve that is located inferior to the 12th rib. These are the orientations I use to do my intercostal blocks. I try to do in plane with both orientations. However, using the longitudinal one where you're doing a cross section of the nerve could be challenging because the angle that you take with your needle may be obstructed by the rib, so you may not be able to gain access. If that's the case, I will turn my probe in line with the nerve and do the longitudinal approach, which is the one above. The dorsal rami of T1 through 12 passes posteriorly to supply sensation to the skin, muscles, and bones of the back. The intercostal nerves are composed of the dorsal horn sensory afferent fibers, ventral horn motor efferent fibers, and postganglionic sympathetic nerves. The major branches of the intercostal nerves are the anterior and lateral. The CPT code is 64420. There's an add-on for additional levels, which would be 64421. And as you note here, the cutaneous branches can come out and branch anterior and posterior, which is pretty important when you're doing the block, because you can actually do a distal block and get proximal anesthesia, meaning you go to that rib distally, and when you do that block, you're not just getting distal anesthesia, you're actually getting proximal because of the nerve will loop back posteriorly for the cutaneous divisions. In case you're in a helicopter or somewhere without ultrasound, have the patients raise their arms and confirm the rib that's fractured or painful. And you can identify in the mid-axillary line or even posterior, wherever you really need to go, which is proximal to the pathology typically. To avoid pneumothorax, obviously use an ultrasound, but sometimes you can't. Either way, palpate the rib with 2 fingers and then stick the needle between them, land on the rib, pull the skin down and guide your needle a millimeter or 2 past the inferior portion of that rib, and hopefully you won't get a pneumothorax. So I don't advise you do this blind, but that's the way you do it. Here it says don't advance more than 5 millimeters. It really depends on the patient. Some patients 5 millimeters is fine. Some patients you have 2 millimeters, and some of these frail older patients who fall and get fractured. I usually use 4 milliliters of 0.25%. Here they're saying to use 2 to 3 of 0.5%. It depends on what you're doing. Here's an image of what the intercostal space looks like. nerve, artery, vein. And of course, the lung and the pleura deeper to that. Ultrasound will give you visualization of the lung. It's pretty, these days the ultrasound probes are much cheaper. You can do it quick, safe, less expensive. There's lots of data suggesting that ultrasound is the way to go with intercostal blocks. You could use this for nephrostomy tube placement by going at the level of T11 or T12. And you could do it in patients with rib fractures, of course. Here's an image of the intercostal nerve under the rib, the intercostal muscles you see as well, and the pleura. Complications, pneumothorax, bruising or soreness at the injection site, bleeding, infection, nerve injury, allergic reaction to medications. Here's an old video. People are doing this for all sorts of reasons. Herpes, zoster, shingles. Yeah, I would do in plain if you're a beginner. And you want to make sure you don't get any side effects or complications. So monitor the patients. I mean, you're in the emergency room, so you have resuscitative equipment available, as well as the ability to place chest tubes, which I've never had to do. So hopefully you won't either. There are plenty of articles on intercostal nerve blocks for rib fractures, shortening length of stay, minimizing opiates, improving pulmonary function, also giving relief for patients who come in with acute or post-traumatic neuralgia, shingles, zoster, etc. You could take care of postoperative pain from lung resections, very useful in post-thoracotomy pain. I see patients a year after thoracotomy, and they have this intercostal neuralgia from their surgical wound that hasn't been treated. And the shot actually could be curative. It could last a very long time, even just using lidocaine. I typically would add steroids, but I find that a lot of the patients get almost complete relief within 1 or 2 shots. Very few number of patients have chronic, and for those patients, you could do neurolysis, but I prefer neuromodulation, which is to place the wire there. I'd rather modulate than kill nerves. The incidence of pneumothorax is very low. I actually got 1 pneumothorax in my whole career. That was just a very, very frail, skinny old woman who I just, I had the ultrasound. I just didn't really appreciate how superficial the pleural space was on her. Okay, so one of the pain doctors I know just got a pneumothorax from a trigger point injection done by a colleague. So, you have to be very careful, and I do recommend using ultrasound. And of course, visualizing your needle tip. In this case, the person who did his trigger point didn't see the needle tip the whole time, and that's what happened. Thank God he's okay, but still, you have to really, you can't take this for granted. Also, these nerve blocks have helped patients with cancer with quality of life improvements. The paravertebral nerve block, it was also popular early in the 20th century. Then it lost popularity. I think people got scared because of, you're very close to the spine. The paravertebral nerve block is basically going in this region, okay? Right next to the spine, almost like transforaminal, but not in the foramen. And you're getting a unilateral nerve block of the spinal nerves, the dorsal and ventral rami, as well as the sympathetic chain. So basically, you're given the local over here in the paravertebral space, and the medication's getting everything. The nerve, the dorsal, the medial branch nerve, which wraps around to get the facet joints and the musculature, as well as the sympathetic nerve. So you can do a lot of good with the paravertebral nerves. It's basically a unilateral block of the spinal nerves, includes all of these nerves mentioned above, but it doesn't give the sympathectomy that an epidural would give. Epidural is neuraxial, so if you're giving local here, you're going to get vasodilation below almost everywhere. Whereas the paravertebral space, you don't get that such an extent of a sympathectomy that there's real hypotension, unless maybe you give large doses. So here are the CPT codes. Now, the first level 64461, second 64462, 76942. This is really an important block, especially at the thoracic level, because you can give one shot, let's say T6, for example, and the drug or the local anesthetic will spread up and down depending on how much volume you give. So, for instance, someone has multiple rib fractures, you give just one of these shots, and you're going to anesthetize multiple ribs with one shot. So that's really helpful, especially if the patient's on a blood thinner, which you may or may not want to be doing these shots anyway, which is a whole nother talk. So paravertebral nerve block indications for surgery, open thoracotomy. And when I say surgery, let's say they come to you with an open, I don't know, wound in the thorax, and they're in pain and you want them to have some relief while the surgeon's coming to do his thing. So, or any sort of post-procedure pain. That surgery, breast surgery, minimally invasive cardiac surgery, renal surgery, open or laparoscopic cholecystectomy, appendectomy, non-surgical problems, post-traumatic neuralgia. There was an article I talked about on the podcast a week or two ago, which you may or may not have heard, where their ER doctors are doing the erector spinae plane blocks in the ER for patients with thoracic zoster, and getting them relief so they could get discharged and follow up with their primaries or their pain doctors. Post-thoracotomy, we mentioned fractured ribs, maternal labor even. I mean, I'm not doing this for labor, but it could be. I've done this for pancreatic cancer pain. Why? Because instead of a celiac plexus block, if you go at the levels of T10, T11, you're getting some sympathetic spread. The celiac plexus comes from those sympathetic splenic nerves. So you are getting relief of abdominal, visceral, as well as somatic pain. Visceral meaning the gut or the viscera, the organs. Somatic meaning the muscles or the fascia or the nerves. There's even people doing the sympathetic block to control hyperhidrosis and even SVTs. Yeah, I'm not using it for SVT, but there are reports of that. So posteriorly, you have the superior costal transverse ligament. It's a continuation of the internal intercostal muscle. Anteriorly, the parietal pleura. Medially, of vertebral bodies, intervertebral foramina, and intervertebral discs. It's a wedge-shaped space that runs up and down. Here you have the lung, which is purple for some reason, the superior costal transverse ligaments, and the pleura, which is a less purplish covering. That was creative license. I didn't really go for accuracy on that one. So in contrast to the cervical and lumbar regions, okay, we mentioned that you could spread up and down. So this is what it looks like when you're doing the block in a cartoon fashion. So you have your needle coming in. You need to be very careful with this, right? You have a spinal cord, you have the lung, you have blood vessels. So this is not a shot to take lightly. This is something you really need to understand what you're doing, how to manage the complications, which could be anything from pneumothorax to vascular puncture to even injecting into an artery that feeds the spinal cord. So that's why I don't recommend giving any particulate steroid here. This is a higher level shot. Patient could be sitting, prone, or lying, or on their sides. The blind approach is what I learned on doing, believe it or not, which as scary as it sounds with an ultrasound, you can imagine how scary it is doing this blind, where you basically stick a needle in and you feel for the transverse process. You're just going blind based on the anatomy, okay? And in the thoracic spine, the vertebral, the spinous processes descend. So you're looking at you're palpating the spinous process of one, but you actually have the lower transverse process right next to it, okay? And you're going in 2 centimeters off the midline until you hit bone, and then you're going to redirect above or below the bone to get into that space. Anyway, that's fallen out of favor. I would not do that blind. Since we have the ultrasound, we could do a lot safer. And if you're really not experienced with this, a better way to do this would be to do the erector spinae plane block, which unfortunately I don't really have any slides here on, but I will try to post them at some point. And that's basically finding the transverse process. And even though we're talking thoracic spine, this is lumbar, it's the same idea. Unlike the ribs, which appear round, the erector spine lies over the transverse process right here, which is a flatter bone. So that's how you recognize when you scan a rib cross section medially, you come more medial, the bone flattens out over the transverse process. And that's how you know you're there. And you just basically infiltrate above the bone under the muscle. I'll have videos for that hopefully soon on the PainExam website. I'm developing a gallery which will be up on the site and will be free to all. It's just not ready yet. So you could position the patient all different ways. So here's how you do the shot with the probe kind of transverse on the back. So the left side is lateral, the right side is medial, and here's your target. There could be a loss of resistance when you get through the superior costal transverse ligament. You want to aspirate before you inject. You want to make sure there's no blood air or CSF coming through that needle. And you can inject 3 to 5 mLs, maybe 1 ml at a time, just to make sure the patient's okay. So here's a little video, the lungs moving, you're scanning the spine, you have the spinous process, the lamina. And we're between transverse processes, so you don't see the transverse process over here. The needle's coming in. And I'm working my way down. Pleura, the target, the needle, and this is what you're looking at. This is a cross section, right? You're looking at the spine. You're scanning it as if you're looking down on the patient. Is that clear for anyone? Does anyone have any questions about this? I use this block for thoracic spine pain in my office. Patients who come in with pain between their scapula, I'll do this if I don't want to give them trigger points for some reason. Complications, fail block, hypotension, vascular puncture, pleural puncture, pneumothorax, etc. Okay, here I'm doing it on a patient, and you see the rib right here. And I'm going between, actually, this is a very nice image of the flattened, it's not really the rib here. I think it's the, it looks like it could be the border of the rib and the transverse process because it flattens out at some point. Here it's flat, and that would be where you put your needle for the erector spinae block. But here I'm just going in between the bones to do the paravertebral block. I'm infiltrating up to here, and my target is where the star is. So unfortunately, the movie didn't get far enough to show over here, but this is where I was trying to get. Okay, so there's a lot of data to support this, how you could use this versus IV anesthesia for certain surgical procedures, for breast tumor resection, for instance. They're using this in pediatrics. They're saying that thoracic epidural and thoracic paravertebrals and intercostals are the top choices for multiple rib fractures, and there's advantages and disadvantages to each technique, which we talked about. Chronic hip pain, you could treat avascular necrosis with an L1, L2 block for postoperative pain control. Epidural and paravertebral have been used for thoracotomy, breast cancer surgery. There's neurolytic paravertebrals you're using for cancer pain. However, you need to be careful because it could track over to the spinal cord and cause paralysis. Okay, the occipital nerve block. In my office, we see a lot of patients with occipital headaches. It could be just because the nerve gets irritated in the cervical spine because the nerves come from C2 and C3, or it can get irritated up through the muscular, fibromuscular canal where the nerve comes out. There could be muscle spasm impinging the nerve. When we're doing these occipital nerve block, we're looking at the atlas, and while we're thinking about the axis and the atlas, it's hard to locate it without an X-ray. But with an ultrasound, you can see the C2 spinous process, which is bifid, meaning it has 2 points, kind of. You want to locate the obliquus capitis inferior muscle because this is where the nerve it crosses over, which is over here on the diagram on the right. The lamina of the axis and transverse process of the atlas as well. That's going to be underneath the muscle. And then the great occipital nerve is hyperechoic. It's above the obliquus capitis muscle. And then there's a muscle above that called the spinous capitis muscle, which you see on the left side. It's a much larger muscle. So the greater occipital nerve is what I'm talking about now, and that's a 64405 code 76942. It's a very specific code. If you're doing the lesser branch, it's a general 64450 code, which is just a general nerve block code if you apply it to many nerves. So here's that bifid spinous process at C2. I'm scanning the back of the neck. And here's a little video of how I do the nerve block. You scan, find the spinous process, go a little bit lateral to it, and you will find the lamina of C2. The occipital nerve is lying between the obliquus capitis inferior muscle and the spinous capitis muscle. Okay, supraorbital nerve block. Maybe someone gets a laceration, you need to suture them up. You might want to do this. This one is really easy to do blind. You're just palpating the foramen. However, you can find the nerve under ultrasound. It's extremely small and very difficult to get your needle there in plane on it with a probe. So you might need to go out of plane. Just make sure you don't poke the patient in the eye. Okay, superficial cervical plexus. This one I use, well, first of all, let me tell you what that is before I tell you what I use it for. So it's from C234, it's superficial nerves. You want to identify with the patient's head turned. The nerves poke out behind the sternocleidomastoid muscle, and they cover between the mastoid process down to the clavicular heads. It's in a plane between the sternocleidomastoid and the scalene muscles. The CPT code is 64413-76942. This is a neck shot, but it's very superficial and very safe if you're doing it right. You're getting anesthesia from basically the lesser occipital nerve and the mastoid process and the lower jaw down to the clavicle. You're getting the whole neck superficially. You're getting where a thyroid incision would be. And the beautiful thing about this is this can treat the pain of clavicle fractures. I use it all the time to treat clavicular fractures, and it works very well. The target is behind the sternocleidomastoid muscle. So you're taking your ultrasound right here, getting a cross section of that muscle. You could see the carotid and jugular, which you stay well away from. And you're just coming in maybe a centimeter or so right behind the muscle, and you're infiltrating 2 to 4 mLs of local anesthesia. And you can get great relief with this. It's a very useful block. Okay, this is the territory it covers. You can imagine how useful that is. The deep block, I don't see people doing much in the pain office or in the ER. I really don't know why you would do it in the emergency room. It's here more for academic purposes. We use this for carotid endarterectomies. So we'll want the patient awake throughout the surgery, so we could do motor testing to make sure, and sensory testing to make sure they're following commands and they don't stroke out. So we'll have them squeeze a toy while we're operating on them, and we anesthetize the plexus deep to the carotid artery. Okay, this is a great one. The transverse abdominis plane block, the TAP block. You're providing anesthesia to the parietal pleurum, peritoneum, and abdominal wall. It's controversial exactly which levels you're getting, but generally speaking, you're getting T7 to L1, all on the belly wall. This is good for acute and chronic pain settings. If somebody comes to the emergency room with a visceral problem, this will not work. You're doing this for a somatic problem. So let's say post-operative incisional repair. Let's say they had a slice, somebody stabbed them or sliced them with a knife in the belly. This could help with that pain. It's been used for appendectomy, hernia repair. In OB, we use it all the time, post-cesarean section pain. I mentioned that we're getting the intercostal T7 to L1, the subcostal T12, and the iliohypogastric and the ilioinguinal nerves. The triangle of Pettit is composed from superficial to deep of the fascial extensions of external oblique, internal oblique, and transverse abdominis, respectively, in the peritoneum. Here's an image of the needle coming in to the transverse abdominis plane, which is a plane between the internal oblique and the transverse abdominis muscle. Okay, here I'm taking the ultrasound and I'm scanning from the mid X-ray line from posterior to anterior, and you see the muscles start to form through the transverse aponeurosis. We're starting to get a view of the fascial layers of the abdominal wall, the muscles. So here we go. It starts right now, transversalis fascia. And here's the characteristic 3 muscle appearance of the internal oblique, external oblique, and transverse abdominis muscles. Okay, so now we're like a little bit more anterior over here. Okay, the tap plane is right between the internal oblique and the transverse abdominis muscle. So it's a very useful nerve block. You can also do a subcostal tap to get the subcostal nerve under the rib. Here you see the rib shadow, and remember I said ribs are rounded, so you see it's round. Transverse abdominis plane, and then the nerve is right under the rib. This is useful for a number of paths. I have a patient with post-operative PEG pain. She has a jejunostomy tube. So she has a jejunostomy tube, and they must have went through some intercostal or abdominal wall nerve when they placed it, and she has chronic pain from that. So I do the nerve block every so often, and she does well with it. Complications: peritoneal perforation, bowel hematoma, femoral nerve palsy, and infection. Ilioinguinal nerve is indicated for lower abdominal groin pain, post-cesarean section pain, post-inguinal hernia repair pain, somatic pain, neuralgia of the ilioinguinal nerve. You could do it for all those reasons. It's a pretty low-risk procedure if you do it right. I guess like everything else, right? So you want to find the ASIS and the umbilicus, draw a line between them, and take the ultrasound and put it on that line and visualize the muscle layers, similar to before, the external oblique, the internal oblique, and then below the blood vessel and the nerve are lying in the same plane. And you have the transversalis fascia. You want to perforate the internal and external oblique once you find the blood vessels, because the nerves are in that plane. And here's another image of that. So here you have the anterior superior iliac spine is this bone right here, and here you have the level of the nerves. Now the problem with this shot, just for technique wise, is you're looking right here, right? And you're coming in from this angle. It sometimes is very hard to get between the anterior superior iliac spine and the probe to get to where you want to go. So one way you could do it is come from lateral, but I think I find it harder. I actually will just take the probe and put pressure this way, so there's room, but I'm still keeping the nerves and the ASIS in view as best as I can possibly. Okay, it's quite easy to visualize. And you have the muscle layers. The internal oblique is typically one of the thicker muscles. Then you have bowel lower down, which you obviously don't want to get involved with. I inject 4 to 7 mLs of bupivacaine, 0.25%. Remember, the more you give, the higher likelihood that the medication is going to track down onto the fascia iliaca and get the femoral nerve. I've gotten a femoral nerve block once on this for giving 10 mLs. So you don't want to give too much local anesthetic. You can give steroid to make it last longer. And of course, warn the patient they may be weak when they get up afterwards. Vascular injection, nerve injury, bowel perforation, hematoma, femoral nerve block are all possible complications. We're going to do spine. I don't think I'm going to take a break because we only have one more unit left, and I think we might not have time if I take a break. I want to finish on time because we have the Super Bowl today. Okay, so any questions right now while I change presentations over? I'm more than happy to answer them. Okay, so for the most part, a lot of the spine is really more for pain docs. I don't really recommend ER docs doing spine procedures in the ED. However, you may have that time where really don't have many options. It's really in the patient's best interest, and if you're properly trained, it might be the thing to do. So let's go. Stellate ganglion blocks, I'm just here to show you what they are. I don't imagine there's much of an indication for it in the emergency room. You do want to treat complex regional pain syndrome or RSD quickly. If you're in a rural hospital, there's no pain docs around. You may want to consider this if you have some accidental intra-arterial, injections. Let's say somebody injects epinephrine into an A-line or decides to inject a particulate steroid, do something crazy and embolize an artery in the hand, and you want to vasodilate. This may be helpful. It's been used for acute herpes zoster of the face, lower cervical, upper thoracic dermatomes. Pulmonary embolism. I would not advise you to go for the stellate ganglion block when somebody has a pulmonary embolism. However, it's written in the literature. People have used it. I assume because it vasodilates maybe the pulmonary artery as well. Maybe that's how it helps. I've never done it for this reason, or do I advocate doing that? I'm just telling you what I've found in the literature. So the stellate ganglion supplies sympathetic innervation to the upper extremity through the gray communicating rami of C7, C8, and T1, occasionally C5 and C6. Some patients as T2 and T3 gray communicating rami innervate the distal upper extremity and don't pass through the ganglion. Hence, sympathetically mediated pain may not be relieved with a satisfactory stellate ganglion block. And just to rewind, in case you don't know what CRPS is, or complex regional pain syndrome, typically it's oftentimes it's a woman in her 20s, 30s, or 40s who had some sort of injury. Could be a man, could be elderly, could be a child, but just more commonly, to give you a brief, there's CRPS type 1, which is RSD, reflex sympathetic dystrophy, or CRPS type 2. And causalgia, when there's an actual known injury, basically the patient presents with allodynia, hyperalgesia, all sorts of miserable things happening to them. It can spread. So yeah, stellate ganglion is one of the things we do early on to try to terminate this whole process from sensitization and worsening of pain, disuse, and misery. Okay, so basically here's an image of the neck. They used to do this blind where you take the carotid, you move it over, they palpate the trachea, you just go in until you feel the bone, which is the C6, hopefully, transverse process. Aspirate, negative, inject, which, as you can imagine, is not the brightest thing to do in the day and age of imaging. Then they were doing it with the C-arm. That's how I trained back in 2007. And the thing with the C-arm is you could give contrast, know you're in the right spot. However, you could give contrast and get an image of the esophagus, and that would be too late. You already perforated it. So I don't advocate using a C-arm. I like the ultrasound. You could see structures such as the esophagus, the superior thyroid artery. This patient here has a Horner syndrome because I gave her a stellate ganglion block, ptosis, meiosis, and hydrosis. She has complex regional pain syndrome of her arm. Here's a superior thyroid artery coming off the carotid. So you don't want to go through that because you could get a hematoma in the neck. Here is the esophagus. I asked the patient to swallow, and you could see right there, okay? That's how you could tell where the esophagus is. One more time. You have the patient swallow. And the goal for this block is to get behind the carotid artery anterior to the longus colli muscle to get the stellate ganglion block. Remember, we discussed the phrenic nerve with the brachial plexus injection. So if you look here at this drawing, the phrenic nerve is very close to the brachial plexus on the other side of the scalene, and you can anesthetize that. So you have to be very careful. Okay, here's an image of the lateral approach, getting the needle behind the carotid from the outside in. And you're injecting on top of the longus colli muscle to get the stellate ganglion. Okay, here I'm injecting some local anesthetic with my needle. You want to do this very slowly, 1 or 2 mLs at a time. Usually 1 ml at a time would be adequate. Here's the transthyroid approach. My needle is that blue line going through the thyroid. And it's very, you're between the trachea and the carotid, a rock and a hard place, right? You really don't want to get either. This is for the advanced but it can be fairly easy when you understand how you're doing it. And here's just a quick video of that. So the right is medial, the left is lateral. I like a 25 gauge 1/2 inch needle. You have to be really careful how you're doing this, of course, because you're going right next to the carotid. The last thing you want to do is inject the carotid, obviously, right? Seizure, stroke, all sorts of misery. Okay, PTSD. Yes, I'm treating PTSD with stellate ganglion blocks on the right side. It helps with the symptoms, the sympathetic symptoms. There are people who've terminated SVT with stellate ganglion blocks. Here's local anesthetic being given. And that's the codes. Okay, so contraindications and the coagulants. I put a question mark because it's probably contraindicated, but some patients, the benefit may outweigh the risk. I can't remember ever doing it on an anticoagulated patient, but just pneumothorax. If the patient had a recent MI, you may get a cutoff of sympathetic drive or accelerator fibers and a bradycardia. Glaucoma's relative contraindication can be provoked by repetitive stellate ganglions. There's some reports of that. Caution with AV block and impairment of cardiac function. Phrenic nerve block, brachial plexus block, neuroaxonal injections, vocal cord paralysis, vascular puncture. Okay, sacroiliac joint pain. Sacroiliac joint is the keystone archway of the back. Okay, the sacroiliac joint supports the back. Okay, it really is an important joint, and it can mimic sciatica. The pain would be in the back / buttock, and it could cause radiation down the back of the leg. Usually there's no numbness, weakness, and usually it doesn't go past the knee, but it can mimic sciatica. Under ultrasound, we can do the injection very easily. There's no CPT code for the sacroiliac joint under ultrasound. There's one that you do it under X-ray. This has to be billed as a trigger point. Last I heard, it may have changed by the time you watch this video, so check with your coders. But basically, the SI joint can now be injected with steroid, PRP or regenerative medicine, or you could even numb the nerves that go to the joint or ablate them, burning them or icing them or neuromodulating them. Facet joints, patients are coming with facet joint arthritis. By the way, SI joint, sacroiliac joint, facet joint, these are osteoarthritis syndromes. So pain is worse in the morning when they wake up, exacerbated by disuse or extension of the back and axial loading. The SI joint can be evaluated by having the patient lie on their back and doing a Faber maneuver, which is flexion, abduction, external rotation of the hip. Basically, they lie on their back and they bend their knee, put their foot on their contralateral knee, and they externally rotate their bent knee. And you put pressure on the knee as well as the contralateral anterior superior iliac spine. Here's a facet joint. Once again, there's a code for injecting facet joints under ultrasound. It's not reimbursed by Medicare. For the last 10 years, it's been considered experimental, even though there's multiple articles documenting that it works and it's safe to perform and cost effective. Medial branch nerve innervates the facet joints. There's 2 medial branch nerves per facet joint. So when you want to numb up a facet joint or block the facet joint, us pain doctors will burn or block these nerves that go to the facet joint to give long-term relief for patients who have osteoarthritis and you don't want to give repetitive steroid injections. Facet joints can be identified in multiple areas. Here's the L5S1. You're looking at the sacrum over here, this long bone with the bone shadow, and the L5S1 joint is just that line above it. It may or may not be relevant for your practice in the emergency room, just for educational purposes. The L5 dorsal ramus innervates part of the upper buttock, the facet joint and the muscles near it. That can be blocked as shown here. It's a longitudinal view of the ultrasound. You have the needle coming in from the left, coming down to the right, and resting right above the bone. You actually don't see the nerve here. It's just too deep and too small to see. But you see the landmarks. Okay, lumbar facet joint, once again, you're looking at a cross-section of the vertebral body. There's a little gap in the bone where the facet joint opening is. It's hard to see here. Here you go, that's the gap. The cervical spine, you have facet joints. You have the body of the vertebral number from C1 to C7, the atlas, the axis, the atlanto-occipital joints, a little hard to see here. So the anatomy is different, the cervical spine. The nerves come out a little bit more anterior. You have vertebral arteries you need to be wary of. You have articular processes over which the medial branch nerves, which is that little nerve that's running posteriorly or dorsally, is, and that will innervate the facet joints as well as the muscles in the neck. So when you want to find the brachial plexus, you could nerves as they leave the spine to do, I don't do transforaminal epidurals because I think they're too dangerous. I do extraforaminal, meaning I basically find the brachial plexus and I trace the nerves backwards and I get them high in the neck. I could do a C6 nerve blocks with the same results as an epidural and way safer using this technique. So here's a trachea, thyroid, carotid, going lateral, and you're seeing the brachial, interscaling brachial plexus like we saw this earlier, right? This is a video we saw earlier, but I'm reviewing it so you could trace back up and find the exiting nerve root. Okay, these circles disappear or they just become black and amorphous because the nerves curve up into the spine. So you're not looking at a cross section of the nerve anymore as a circle. It becomes longer, a longer black structure. Okay, so the needle is right there over the articular process of the posterior tubercle, and we're seeing the location of the exiting nerve root, and the probe is to the side of the neck. Okay, like I said, I don't know if you're going to be doing this, but I just want you to understand the anatomy. Here's a vertebral artery. Okay, you have to be very careful in the neck. There's a posterior tubercle or articular process, I should say, of the cervical spine. The nerve is somewhere between them. Cervical facet joints, they can get arthritic pain with extension of the neck. Typically it's axial, but can refer to the arms or legs. If you think patient has cervical facet problems in the ER and you just want to get them home, you could carefully give lidocaine. I would not stand them up and give them any, or sit them up, I should say, and give them the injection into the joint in the ER because there's a high incidence of vasovagal hypotension. I would basically give them a trigger point, which this lecture actually goes a lot more involved and deeper than the trigger points. The trigger points are just injecting the muscles above my blue arrows. Or if you're really confident with your skills, a cervical medial branch nerve block at the point of their pain, at the level of their pain. You see here the medial branch nerves, they branch off posteriorly of the exiting nerve root. The exiting nerve root's descending and running anterior, whereas the medial branch is going posterior and dividing into the branch that innervates its own facet and the one that descends to the facet below. So here you're looking at the almost coronal section of the lateral vertebral body, where you have the bone shadow and above it a hyperlucent structure, which is the medial branch nerve. And that could be injected if you come from a posterior to anterior approach. And if you keep your needle in plane the whole time, you just pass through the muscle. There should be no major blood vessels back here. And 1 ml of local anesthetic could help. This is that medial branch in just a different angle, coming more from an oblique view. You could also just give trigger points above it, and that will probably help get the patient out of the emergency room. That's probably what I would do. I'm not recommending coil epidural steroid injections in the emergency room. However, if you have to for some reason, there's no pain guy around, and the patient you really don't want to admit, and you're very skillful in the shot as well as understanding the complications, the shot is indicated for lumbosacral radiculopathy. It's good when there's hardware in the spine because you don't want to do an epidural at the level of the hardware because of risk of dural puncture and headache, or just aberrant spread of the epidural. Here's a little video of a coil epidural steroid injection. Okay, the cornu. the sacrococcygeal ligament. That's called the frog sign, those two cornu. Okay, you just turn it longitudinally and you visualize the opening. Scanning to the side and then medially again to get the cornu out of the way. And you see my needles anesthetizing the tissue. And here I'm going to guide the epidural needle, which you can use a spinal needle for this. It doesn't have to be an epidural needle, into the caudal space, which you'll feel a loss of resistance, and give a combination of saline and steroid here. And it spreads up to the lumbar region. If you give enough volume, you want to give about 8 or 9 mLs. Okay, and then you'll finally pass this into the caudal space. And that's the injection. Some of it goes retro, some of it goes, and most of it goes anterior. Okay, so you have the lumbar sympathetic, the superior hypogastric plexus. These are the sympathetic nerves that innervate the pelvis and lower back and legs. The ganglion impart is a ganglion in the middle. It's not paired. They converge. The sympathetic chain converges here anterior to the coccyx. And this ganglion will provide innervation to the coccyx, the perineum, and the genitalia. The S1 foramen, if someone has a radicular pain and you can't do an epidural, you don't want to do a caudal, you could actually stick a needle into the foramen and give them a shot. There's no real code for this, so most people don't do it. So it may not be reimbursed. And, you know, it's a more higher level shot that I'm not recommending you do. Most pain doctors don't even do it this way. The cluneal nerve blocks, you may or may not have heard of them. You may or may not remember them from medical school. These nerves have been ignored. I learned them in med school, forgot all about them, didn't think about them when writing the pain board review I did. Practiced pain management for at least 10 years before I started to realize that these are nerves that can be causing pain because nobody talked about them. It's with the neuromodulation that people are starting to talk about them now, because there's a such thing as a superior cluneal or a cluneal nerve entrapment syndrome, in which the nerve gets irritated and you have pain in the more the cutaneous or the muscle regions depicted here. You have the superior, middle, and inferior cluneal nerve branches. To diagnose it, you have low back pain going to the iliac crest and buttocks. Symptoms are aggravated by movement or posture. Trigger points of the posterior iliac crest correspond to the nerve compression zone. Patient reports numbness and radiating pain in the superior cluneal nerve area. There's Tinel's when the trigger point is compressed. There's symptom relief by the blockade at the trigger point. And here's the diagnostic criteria. There may be a Tinel's over it, relief with the block. And this is typically where the nerve will pass. There's a middle branch, medial branch, and lateral branch, and it can refer down to the buttocks. Laterally.
Superior cluneal nerves originate from the dorsal rami of primarily the upper lumbar spinal nerves. The nerves cross the iliac spine to innervate the skin and subcutaneous tissue over the gluteal region. The nerves extend as far as the greater trochanter, and the area of innervation may overlap anterolaterally and the iliohypogastric and lateral femoral cutaneous nerves. A reliable nerve block technique may have the application in the management of postoperative hip pain surgery as well as other clinical conditions, for example, chronic low back pain. This superior cluneal nerve block will anesthetize the skin posterior to the area innervated by the iliohypogastric and subcostal nerves, improving anesthetic coverage for hip surgery. A diagnosis of superior cluneal nerve and medial cluneal nerve entrapment may be made by palpation of the iliac crest or long posterior sacroiliac ligament, resulting in marked tenderness and provocation of symptoms, and pain relief with local anesthetic injection. The superior cluneal nerve tender point on the posterior iliac crest is approximately 70 millimeters from the midline and 45 millimeters from the posterior superior iliac spine. And the osteo component of this tunnel is the rim iliac crest, and the fibrous component is the tough thoracolumbar fascia. Now that's the medial branch of the superior cluneal nerve. Now this is a patient who originally had a sacroiliac joint injection as well as gluteal trigger points, gluteal bursa injection without any long-term relief. And on exam, she did have a positive Tinel's near the iliac crest, right where my needle is and where I'm working. And what I did first is a longitudinal view, and I identified and anesthetized a medial branch of the cluneal nerve, and now I'm doing a cross-sectional view with a transverse approach. And the nerve is quite small and difficult to identify, and the best way to identify a positive nerve block is to have the patient report response with only 1 or 2 mLs of lidocaine 2%. This patient did very well and is going to go on to peripheral neuromodulation. This patient had a laminectomy and axial pain to the right side, radiating to the buttock and hip. He was unwilling to come for a fluoroscopic facet or medial branch nerve block, and in the office I performed a superior cluneal nerve block at the higher lumbar regions where his trigger points were, that were radiating down to the lower back, buttocks, and side of his hip. Upon going towards the more superficial hyperlucency, the patient reported concordant pain. Upon redirecting the needle and depositing 1 ml of lidocaine 2% at the deeper trigger point or hyperlucent spot, the patient reported pain that correlated exactly with the superior cluneal nerve distribution. It radiated from this region down to his buttock and side of his hip. Patient reported immediate pain relief and is to be followed up in the office for possible repeat injection or maybe peripheral neuromodulation in the future.
So I'm showing you this because this is something that's commonly misdiagnosed as a gluteal or lower back trigger point, meaning patients will come in with pain in the gluteal region or a trigger point tender spot at the PSIS. They'll say that ball in my back is hurting me. It's really tender there, especially if it's a little bit lateral to that. If it's medial to the PSIS, I'd say it's more probably facet joint problems. But if it's lateral, I'd say it's the trigger point. Here's somebody with a spinal cord stimulator. I'm just showing you what it looks like. Here you have a shadow, and that's the wire coming from the patient's spine. And I'm doing a shot where I'm going underneath the spinal cord stimulator to anesthetize the cluneal nerve. And this patient wound up getting a peripheral nerve stimulator after they had a spinal cord stimulator. Okay, this is me doing a peripheral nerve block. I'm sorry.
The lateral branch of the superior cluneal nerve.
Like I said, lateral branch of the superior cluneal nerve.
We're going to anesthetize the lateral branch of the superior cluneal nerve. Patient had a fall and is complaining of pain in the region. The cluneal nerves originate from the dorsal ramus of the upper lumbar levels, and they run down towards the buttock and give branches that innervate the region near the iliac crest as they pass over it, as well as even to the lateral aspect of the hip.
Let's see the iliac crest.
The bone shadow here is the iliac crest. I'm scanning from side to identify the nerves. We're too deep, so I'm going to reduce the depth. And right here is a lateral branch of the superior cluneal nerve, which is right over the patient's tender spot. This is a cross-section of the nerve. These nerves pass through a fiber osseous tunnel as they cross over the iliac crest and descend. a little pinch. Is that the spot? And give the rest of the injectate. Come to the other side of the nerve. And that's the lateral branch of the superior cluneal nerve over the iliac crest.
So as you see, some patients have trouble lying prone for these shots. So we even stand them up, and you have to know your patient. And depending on the type of shot you do, vagling is really not an issue as much for certain patients and certain procedures, where it is with others. So you have to just know your patient and your problems. The medial cluneal nerve can mimic SI joint pain. It comes from the sacral foramen S1 through S2, and it runs laterally to innervate the buttocks, the muscles. There's the posterior long sacroiliac joint ligament, which actually runs from the PSIS down to the sacrum and can entrap this nerve, causing a pinched nerve type pain radiating to the buttocks from the back right below the PSIS. Okay, that's where the ultrasound is being placed, visualizing the ligament. Okay, here's an image of the S1 foramen, the L5-S1 facet. The ultrasound is placed longitudinally, and we're scanning laterally to find the cluneal nerve. It's very small, and it's right there. Oh, sorry. Right there. Okay, that nerve goes through the ligament and then go innervate the gluteal muscles on the other side of the iliac crest. Similar to the superior cluneal nerve, the trigger point is 35 millimeters caudate to the PSIS. And these are pretty low risk shots that you could do if you find patients who have tender spots here. The inferior cluneal nerve is a nerve or of the posterior femoral nerves. It's cutaneous. The ganglion impar lies anterior to the coccyx. I don't want to spend too much time on stuff that you're probably not going to do. It's actually 4 CME credits, not 3.5, but the code is 50 SURD. I really wanted to thank you all for being a part of this today. I left 10 minutes free to talk about, to answer any of your questions, and mention that I do plan to do live training. Like I said, first come, first serve. So if you're interested, shoot me an email. I can register you. There will be a link to register on the website as well, and my newsletter, which you could sign up. Currently, there's a link on the PainExam page for this event where you can just put your email in and get emails. But if you signed up, you'll get it. This is more for your colleagues who don't know about this. Please spread the word. NRAP is going to be developed over the next few months. It's my new, I guess, website that's going to be more of a platform for all physicians who treat pain, not just pain doctors. And there'll be CME activities, as well as links to galleries, free content, schedule for more courses, etc. So if you could just keep in touch with me and spread the word, and let me know if you're interested in the live courses, I'd greatly appreciate it. In the meantime, are there any questions that I may have skipped over or missed? Okay, well, I wanted to thank you all for joining me today. I know it's a lot of time to spend on Super Bowl Sunday, take away from your family, but I appreciate it. And keep in touch with me. If you have any questions about these nerve blocks, you could shoot me an email. And I'd be more than happy to tell you how I do it and give you some more advice, okay? Take care. Good luck to you all.